Good evening, everyone. Welcome you all to this All Aims webinar of OPHTHAFEST 2020. In this difficult time of COVID pandemic, when we are all not doing much of cataract surgery, so let's hear from the experts on the practical tips of how do we manage cataract management from basics to advanced and enrich our knowledge. This webinar is specially designed for all the ophthalmologists in practice and for all the residents in training to enhance their skills. So hope all of you will enjoy and benefit from this interactive session. We shall take up questions after 2 or 3 talks, and you have a chat box in which you can post questions, and we'll try to answer all your queries. So now I welcome our 2 chief guests. We have Professor Mahipal Sasdev, who is the president of AIS, and Dr. D. Ramamurthy, the chairman of the Eye Foundation. We have all the professors from AIMS New Delhi, and we have 6 HOD from the new AIMS, that is AIMS Rishikesh, Raipur, Jodhpur, Bhubaneswar, and Patna. So now I request Professor TTL sir to give the welcome address and put the session on. To you, sir.
Good evening, friends. Indeed, it's my pleasure to be in this webinar today. First of all, I would like to congratulate Sucheta for organizing this webinar and thinking of getting all the aims together. And rightly said, cataract surgery is one of the most common surgery in our human body. And even a COVID time, this is again the most done surgery nowadays in the month of July, August. And whatever we say about number of webinars, lectures, videos, still cataract surgery requires some more teaching tips, because every year we have hundreds of new ophthalmologists joining ophthalmic department, and cataract surgery requires surgical tips. Not everywhere we have a good wet labs, so it is these type of discussion which will really help our people. So thank you all of you for joining us. Today we are going to take you from basics to advanced surgeries, right from manual surgery to laser-assisted femtocataract surgeries. And we have a galaxy of speakers, people who have experience of more than 30, 40 years in this field, and they are world-renowned in this particular area, and their surgical tips will be really handy to all of us. It's not that you are only learning, we also learn every day listening to our friends, and that is what going to happen today. And I welcome all of you, especially AIS office bearers, Professor Mahipal Sasdev being AIS president, and the largest cancer hospital in India, Center for Sight, Dr. D. Ramamurthy, the past president of AIS, and they also have the large sector of ophthalmic care across the southern part of India. Their experience will be really handy. Professor Namrata Sharma and Dr. Tushar and Dr. Rajesh and myself from the AIMS New Delhi team. Then you have a various head of departments, right, as you rightly said, from east to west. I welcome all of you. Let's have a good discussion for ourselves as well as for the people who are joined today through this particular Zoom thing and Iskeres platform, that is YouTube and Facebook. I thank you, Dr. Rajesh, for giving us this help to Dr. Sucheta and organizing this workshop, this webinar. Sucheta, you can call the first speaker, please.
So now since we wanted to start from basics to advanced, but due to constraint of some other webinar going on, so I'll call our first keynote speaker, that is Professor Mahipal Sasdev, to give his talk.
Thank you very much. Thank you very much, Dr. Sucheta. Thank you very much, Professor Pratical, Rajesh. Always a pleasure to be with all of you, and also having spent about 20 years in AIMS and all the new AIMS, it's always a pleasure to see colleagues as also other AIMS who are doing well. So I'll be talking on femto laser, and that is something that we have adapted a couple of years ago and are reasonably happy with the outcomes. Rather, I feel that it's a paradigm shift nowadays. So I'll start my presentation. Everything visible?
Yes.
Okay. So I'll be talking laser assisted cataract surgery, and I have no financial disclosure as such on this presentation. However, I'm a consultant for J&J Vision, as things are. I would just wish to say that any technology that comes, the most important thing that that technology has to do is that it has to add something to the present technology that is available. A lot of people have debates and discussions about phaco versus femto. I think it's not versus anything, because these are complementary technologies and they add each other. It's not that you can do a femto with. And what is important is that the difficult and the challenging cataract that we are talking about. So something that the femto procedure does is that it simplifies the complex cases, and I'll be talking about the complex cases in this presentation that is there. Now, what is very, very important is that the patients that we are seeing in COVID times, yes, we are seeing a lot of mature cataracts, etc. But pre-COVID, there was the younger patients were also coming in with the cataract, and they were highly aware and active. They wanted an active lifestyle. It is not that they were old people who are retired, etc. There are young people as also maybe old people.
Sir, your voice is breaking, so can you put your video off?
Span of individuals gone up, so 70,
Sir?
75 people are working still. You have a very active prime. Okay.
Sir, voice is breaking.
Sir, your voice is breaking. Can you put your video off so that we can hear your voice clearly?
Admin, you can mute everyone except sir. Hello.
No, his network is not supporting actually.
1 second. Is this all right now? Let's try.
Yes, sir.
Okay. So basically what we are talking about in the patients is that they have, they want a very high rate of post-operative satisfaction, and they are looking at spectacle independence that is there, that they should reach the target of hematropia, and they are willing to pay the premium that is there. Now, what is important is that when you are looking at a femto laser cataract surgery, it is making certain steps which are repeatable in everybody's hand. And these steps are basically, you have the capsular access, which is there, which is the primary and the secondary incisions, which is there. And then there is the nucleotomy, which is being done by the femto. So the attempt is that femto cataract, because it is being repeatable in everybody's hand, is being attempted to be made akin to a refractive procedure. And the capsular access being perfect in everybody's hand is likely to give you a good effective lens position, and also not have shifting of the lens from its position. Lens fragmentation reduces the phaco time, and the incisions being multiplanar, as also having the arcuate incisions for low degree of astigmatism correction are the important things that are there. Now, apart from having a repeatability and trying to make the procedure more towards a refractive surgery, let us look at the simplification of the complex cases of cataract. The first thing that we would wish to talk about is a posterior polar cataract. As you all know, this is a typical look of a posterior polar cataract that you have. And in posterior polar cataract, several authors have shown that there is a pre-existing weakness in the posterior capsule. And this causes a rent in about 30 to 35% of the cases. Ever since we have switched over to the femto, we have not had any nucleus drop that is happening, because you are able to image, and I'll be talking about Dr. Titial and Namrata and Rajesh are here. They have also done extensive work and have publications. Now, what is important is that if you do hydrodissection in a polar cataract, you can cause hydraulic rupture of the posterior capsule. But if you switch over to the power of femto, the femto laser does a pneumodelineation rather than a dissection. And this eliminates the need for any hydrodissection or delineation. The other thing is that you have a pre-chopped nucleus, you have small fragments, and therefore it simplifies the nuclear removal which is there. Now, this is a publication that we have in the Journal of Cataract and Refractive Surgery, where we have used the imaging technology of the OCT to detect pre-existing posterior capsular dehiscence and to increase the safety margin in posterior polar cataracts. So what I'm going to show you is that this is a case where you can see very clearly and elegantly that the posterior capsule is defective, and therefore the surgery is planned accordingly. Now, this is the OCT image. You have the cornea, you have the lens, and you can see here that this is the area where there is a huge defect in the posterior capsule. So once you have done, you have lifted the default settings above, and you can see that without any dissection, any hydrodissection, etc. that I did, and without any rotation, we were able to get a good posterior polar separation of the entire nucleus, taking it out with the epinuclear cushion. And you could see it is right at the end that we got a defect. So the imaging that you get from the OCT helps you see these defects and to get good outcomes. So the femto advantage in posterior polar is that femto delineation enhances the safety. It softens the nucleus and helps tackle harder grades of cataract. And there is a perfect CCC. So as you could see in the case, because of the perfect CCC, we were able to do a sulcus implantation. Now let us see, is it possible to work in small pupil? Earlier, when we were talking about femto, it was said that small pupils, you really cannot do a femto procedure. So you can see here that you can insert a Malyugin ring and go ahead and do the procedure. Let me just show you a live image. So you can see here that this is a patient who has iris atrophy, had an attack of angle closure glaucoma, and you can see that a Malyugin ring is being implanted in this particular case. So if you have a Malyugin ring that is implanted into a patient, you can actually just have a little bit of a visco at the tip, and you can remove the rest of the visco, and you can see this is a subluxated cataract, and you can get out a very good capsulotomy, which would be difficult otherwise in a subluxated cataract. And you can see that you get the nucleotomy which is there, so you can manage this cataract well. So subluxated cataracts with small pupils, you can easily work here. Now, if you look at phacomorphic glaucoma, you have the possibility of Argentinian flag sign. So you can see in this particular case, it was a swollen nucleus. And you can see that phacomorphic glaucoma, there is a touch of the iris to the back of the cornea. Here you can again see, and you just see here, there was a huge amount of lenticular fluid that came out, but the capsulotomy you could get without any extension. So you have to use trypan blue in this particular case. And just at the lower point, there is one small tag, but you can easily remove the capsule. So what happens is that in case of hypermature cataract, because you have not opened the chamber, you rarely get a runoff of the capsule. You can, but the incidence of having an Argentinian flag sign or having a runoff is very, very difficult. Now, when you're looking at a rock hard cataract, we can see that until, of course, we are looking at white cataracts, we have the transparency of the nucleus. Under those circumstances, we can have the femto fragmentation that can happen. So you can see this is a capsulotomy that has happened in a black cataract, and I'll just show you that. You can see this. Can you see the split that is there and the black cataract that comes out? And you can see that we are having pre-chopped nucleus which is there, and the outcomes are pretty good. So again, you can see that segmentation becomes much easier in cases of hard rock hard cataracts, and you can get out good outcomes. Earlier, again, when we were looking at small corneal opacities like RK, etc., there was an issue that was thought that we should not be doing femto, but it could be a relative contraindication. What you have to do is that because of the risk of laser penetration being less from the areas where there are scars, you have to not place an incision. So corneal incision should not either be placed between the scars, or you should not have the corneal incision placed. There could be capsulotomy tags which could happen, but the phaco gets simplified. So let me just see in this particular case, what you have to do is that you have to increase the energy. You can see this is a cornea which is flat in the center. You can see there are multiple tags, multiple RK incisions which are there. We have increased the energy and we have got a good nucleotomy. Nucleotomy is never a problem, but you have to stain the capsule. So see here, you have stained the capsule. There are 1 or 2 adhesions that you can see below the RK marks. But see there, that's the incision. You have to just be very careful that the RK had worked as a barrier. So if you have a good rhexis forceps, you can remove it. And once the nucleotomy is done, you can go ahead with very little phaco power and get a good outcome even in post-RK cases. Now, when you are looking at vitrectomized eyes, often there is posterior capsular or zonular weakness. The scleral rigidity is low. Corneal endothelium can be compromised. But what is most important is because of the capsular fibrosis and compromised red growth, there could be a difficult CCC. And one contraindication is that if there is silicone oil in a posterior segment vitrectomy case and the emulsified oil is in the anterior chamber, you should avoid a femto because it will not allow you to cut through the emulsified oil that is there. So this is something which is important, that in silicone oil, if you have emulsified oil, you should not have it. You should not have a femto. Now let us look at a case finally of a post-traumatic subluxation. You can see that there is a huge subluxation in this particular case. And when we are doing a femto procedure, you look here, this is the iris which is coming down as compared to a straight iris here. And this is a vitreous blob, which you can see widely. There is a vitreous blob which is there. So when you are doing a femto procedure, the vitreous will not cause any trouble. You can center your capsulotomy the way you want. You can size your capsulotomy the way you want. And in this particular case, we are having the posterior approach where we are first going in after doing the capsulotomy and the nucleotomy, putting in tricot, and whatever vitreous that I told you which was coming, we have removed the vitreous so that we do not have more subluxation. This is an endocapsular ring that has been inserted right at the beginning of the procedure. And you can see because of the fact that we have pre-chopped the nucleus, we are able to remove the nucleus pretty well and the capsule is centered well. I'm sure that if you were doing a normal phacoemulsification, that would have been a problem. So the posterior approach of removing the vitreous first, once the prices of the machine and the patient interface comes down, it would be a standard of care over the next couple of years. So these were just to show you that how we can use the power of femto to simplify difficult cases. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Mahipal, sir. It was a wonderful overview on femtosecond laser application in cataract surgery. And you rightly showed the application in all types of cataract surgeries. And we know that it has real value in difficult case scenarios, especially posterior polar subluxated wide cataracts, and definitely in a dense hard nuclei where laser energy will decrease so much, won't affect the endothelium as such. Any questions from the panel here? Dr. Rajesh?
Sir.
Dr. Mahipal talked about, post vitreoretina cases where silicone oil is there. What is your
Sir has very rightly pointed out that if there is oil in anterior chamber, it will be difficult to do the femtosecond laser. There is another advantage. In some cases in eyes wherein oil is there in the posterior chamber, in the vitreous chamber, what happens is that there is some zonal dehiscence, some zonal damage in all these, most of these cases wherein VR surgery has been done and oil has been put in the vitreous chamber. So when you start doing manual cataract surgery, sometimes even if the oil is not there, there's a tendency because of the stretch in the zonules that the oil comes into anterior chamber. And that makes the surgical area messy a little bit while the rhexis and all that. So femto has that advantage. We did a study, a thesis, and we found out that in about 40% of cases, there was some droplet of oil that came while doing a manual rhexis. While when we did the femtosecond laser rhexis and capsulotomy and nucleotomy, so none came because it was a closed chamber procedure. Also an additional advantage using femtosecond laser in oil-filled eyes.
Yeah.
So, Rajesh, I completely agree with you. The only problem is that in case the emulsified oil is being shown when a patient lies down and you get the oil globules wherever it is, either you use a trypan blue at that time, because wherever the oil globules, it normally comes as a shape or whatever it is, below that area will be cut. But apart from that, what you have rightly said is that is subluxation, the oil can come back manual. And also, if there is fibrosis, that is also helpful by doing a femto. But if you have a lot of emulsified oil, which at times is not visible when you are doing a slit lamp examination, but when the patient lies down on the femto table at that particular time, it becomes visible. So that is a
Sir, we found out that some cases wherein even if there was no oil in anterior chamber, while doing the manual capsulorhexis, some oil, came through the stretch zone use.
that I understand. But what I am saying is that if it is already pre-existing, that is the time. If you don't have any pre-existing emulsified oil, it is the best thing to do.
Cases?
I think it's a wonderful to help you manage subluxated cases. Essentially, it's the positioning of the capsulorhexis which is extremely important. And in these situations, it should be centered on the capsular bag and not on the pupil center. So in these cases, it is possible to decenter the capsulorhexis exactly where you want, still get a nice 5 millimeter rhexis where you want it. And once you have created this, then you can, the major advantage of the femtosecond laser in performing the capsulorhexis is that you are able to do the rhexis in a closed chamber. Whenever you are doing it manually, whether it's intumescent cataract, whether
Thank you, sir. Dr. Mahipal, sir, what do you think in a COVID time, femto surgery will be okay? Are you doing femtosecond laser surgery also?
So actually, my percentage of femtos has increased. I don't know what is the reason, but I think 75% of my cases are getting femto done nowadays. I really don't know what's the reason, but
is it more safer? I'm just asking question because of COVID, you have to have patient in a laser setting first, then shift to the main OR subsequently, or it doesn't make a difference?
I don't think it makes any difference, because in any case you have a pre-treatment with betadine, povidone, iodine, and then you have the mask, etc., which is there. And in any case, you have to use a new LOI for every patient. So I really don't. I haven't really had any problem from then there is no. Actually, it might be, if, thinking about it intuitively, the amount of energy or aerosol generation. There is no aerosol generation when you're doing a femto procedure, but when you are doing the main surgery where the chamber has been opened, when you have to do a capsulotomy, etc. So that's already done, and the nucleotomy is already done, and there is to show that 50% reduction in phaco time is there. So maybe the aerosol generating part is less in cataract, or otherwise we haven't seen any specific report in world literature of transmission of COVID. So I don't think it decreases the safety. It may increase the total time of the patient by a couple of minutes, but otherwise there is, I would say that intuitively it might be safer.
Okay. Thank you, sir.
Sir, I have one query. Sir, in subluxated cataracts, after doing the capsulotomy and all, in order to maintain the lens in the center, do you use lens hooks, or you directly put the capsular tension rings?
Not capsular. You should use capsular hooks if required, because when we put the endocapsular ring, it kind of went back, and we had a decompression from the back. So in case you feel that it is extensive, there is going to be a problem, or there is a donosis that is happening, then capsular hook should be good. These are again, I would say, complement each other rather than being this versus that. So endocapsular ring is going to stay there throughout. Capsular hooks basically provide support at points where they are, then the rest of the area where the vitreous or something is coming out cannot be.
Any time you found that the capsule got ripped with this?
A capsule can get ripped more with iris retractors being used as capsular hook, but if you have the shape of a capsular hook, it tends to not rip. But I have not, fortunately, not had a rip, because there is a lot of consideration as people feeling that the capsulotomy is weaker as compared to a manual capsulotomy. It may be correct, but I think it is strong enough to hold even the capsular hooks and the endocapsular hook. So it
Thank
was
you, sir. Thank you.
earlier I did have with the Lensex where we didn't have the soft fit. At that time, the dock was hard, and because of the posterior capsular notches that used to come in, well, not posterior, I mean endothelium or the posterior corneal depressions, indentations that came, you could have skip areas. And that is where I have one or two old videos where we had an extension, but not now with the soft fit that is there with the cataract.
Okay, thank you, sir. I think we can shift to the next speaker now. I request Sucheta to introduce the next speaker. Can you have the slide?
You are muted, Dr. Sucheta.
So our next guest speaker is Dr. D. Ramamurthy, who is the chairman of Eye Foundation chain of hospitals in South India. He is the past president of AIS and chairman scientific committee of AIS for past 6 years. His interest of area is in cutting technology in cataract and refractive surgery. He has confirmed with a lot of awards and oration, and he is a brilliant orator and surgeon and a true gentleman. Over to you, sir, for your
Thank you very much, Dr. Sucheta, Professor Titial, for inviting me to this wonderful webinar. I know that I am in the midst of the elite, that the best of ophthalmologists from the All India Institute are there. But I do believe that I have a right to be here, since I consider RP Center as my alma mater, and whatever little we have achieved today is essentially because of the grounding and the training that we have in this wonderful institution. So my topic is disruptive IOL technology in monofocal cataract surgery. By way of financial disclosure, I'm a consultant to J&J and Alcon. And basically today, cataract surgery, as all of you know, is not considered as a vision restorative surgery, but vision enhancing surgery. Not just the removal of the opacity that matters, but also the ability to give the patient the kind of quality of vision that he or she did not have right through their lifetime. So what matters today is uncorrected visual acuity for all distances, not for distance alone. It's also the best to enhance the quality of vision. What matters is the immediate restoration of vision. And since we are operating on patients with visual acuity of 6/9 or 6/9 parts in their 40s and 50s, and they will far outlive our own professional lifetime, obviously what we do today has to subsist the patient for a very long time. So there have been multiple IOL options that have been available to us: the monofocal implants, diffractive multifocal, the EDOF lenses, trifocals, accommodative, light adjustable, etc. Most of the conversation, most of the discussions, presentations, literature is essentially on all these lenses. But what we need to remember that even in advanced countries, majority, 95 to 96% of the implants that we place are monofocal intraocular lenses. Why is it so? Even though that it stands to reason that if you are operating on a 50-year-old, just like you would not prescribe glasses without correcting presbyopia, ideally you should be placing multifocal intraocular lenses. All these multifocal intraocular lenses work on the principle of simultaneous macular perception, where the object of regard and direction of gaze essentially determines which object is under focus and which is not. What you have is essentially the signal which is brought to a precise focus onto the fovea, and there is this noise which essentially diverges over there and causes a blur. So whenever you are talking about multifocality, essentially you are buying vision at all distances or different distances using the currency of contrast, and there is definitely a certain amount of deterioration in the quality of vision that these patients have to put up with. So depending upon the company whose slides you're using, there are different representations of glare, halos, as well as night vision difficulties that's represented. It's simply because when you implant a multifocal intraocular lens, you're doing something non-physiological. We have always, as clinicians, we have found that when we imitate physiology, we get the best of results. When the BP goes up, we bring it down. When a clear lens becomes opaque, we remove it and replace it with another clear lens. Multifocality was never in the scheme of things as far as nature was concerned, either in the cornea or in the intraocular lens. That is the reason that whenever you do a multifocal ablation on the cornea or implant a multifocal intraocular lens, there's always a price to pay for it. And essentially, that's the reason that multifocals have not been completely taken up in spite of various other options available. So why do I call this a disruptive technology? One reason is, of course, this was the topic given to me, but I do agree with it because would it be possible to re-engineer the proven monofocal platform to gain some optical advantage? Even though the monofocal intraocular lenses have been around for quite a long time, and the foldable intraocular lenses came in 1995, aspiracy in 2001, subsequently, there have been only minor advances that have taken place in haptic design, addition of yellow pigmentation, square edge modification for PCO prevention, etc. Basically, as far as the optical concept of these intraocular lenses is concerned, there's hardly any advancement that has taken place. And that is the reason that the most widely used intraocular lens, that monofocal intraocular lens, can we re-engineer it to provide some kind of an optical advantage. And we have a very stable, tried and tested platform in the Technis platform, in the sense it has an aspheric design with a Q value of minus 0.27, which almost completely neutralizes the corneal anterior corneal asphericity. And then it has a reduced chromatic aberration capability because the high Abbe number, proven lack of glistening, reduced PCO because of the posterior square edge, as well as the hydrophobic acrylic material, because of which there's a less tendency for capsular phimosis. So on this very stable, established platform, we have the Technis Eyhance intraocular lens, and I believe that's a significant advancement as far as intraocular lenses are concerned. When it comes to a naked eye examination of the Eyhance, it exactly resembles the Technis 1, not differing in any particular way. It has a continuous change in the power from the periphery to the center. And it is this unique anterior surface that improves the intermediate vision as far as this lens is concerned. Mind you, it provides intermediate vision, but at the same time doesn't cause any deterioration in the distance vision. There's no dysphotopsia that these patients have to deal with, and because of the asphericity concept, the spherical aberration that the patient is left behind is almost zero. Essentially, 85% of the anterior surface of the lens almost resembles completely the Technis intraocular lens. There is only a gradual gradation of the power from the periphery to the center. It's only the central 15% of the so where this is a slight increase in the power, and this is something which is not distinguishable by the human eye or even under the microscope. It's not a zonal progressive lens like the array. It's not a diffractive multifocal like the commonly used multifocals that we often use. Neither is it a modification of spherical aberration, but it's a very gradual increase in the power of the lens from the periphery to the center. Essentially, clinically, it translates to the fact that it has as far as the defocus curve is concerned, it has a much higher sweet spot. While you can see what you see in this gray line over here is the defocus curve for the Technis 1, and what you see over here is for the Eyhance. You might think that it sort of resembles each other, but the most important factor is the difference over here. Even with a defocus of about 1.5 diopters, still the patients are able to maintain a visual acuity of 6/32 or better, which translates to 20/32 or better, which translates to a vision of 6/9. Essentially, thus it is enhancing intermediate vision quite significantly. So this is just a video of the Eyhance intraocular lens. It's actually no rocket science. It's essentially shown to emphasize the fact that implanting these intraocular lens is absolutely no different from implanting a routine Technis 1. It comfortably goes through a 2.2 or a 2.4 millimeter temporal clear corneal incision. As you could see, the lens looks no different from the conventional single piece hydrophobic acrylic Technis 1. And what you need is a good phacoemulsification, good overlap of the intraocular lens with the rhexis margin, and that's the end of surgery. And as far as the measurement of these lenses, I'm not going to do a literature review, but very briefly dwell upon our initial experience. We have implanted more than 100 of these lenses now. We essentially measured both at 40 and 60 centimeters. And the combined defocus curve was something which was extremely satisfying. This is the most important point I want you to concentrate on this extremely flat defocus curve with even a defocus of minus 1.5 diopters, you get a visual acuity of between about 0.1 or slightly less than that. Again, you have to understand that once the defocus improves, there's a significant drop in the visual acuity. So it's essentially not good for near vision. I often find that you require about plus 1.25 to 1.5 diopters when it comes to comfortable near vision. So the patient is able to function well for a distance without dysphotopsia, have good intermediate vision, but in case near vision is a requirement, then there's a readers that's required. And this is again another representation. The average logmark distant corrected visual acuity, even with a minus 1.5 diopters of defocus, that is in the range of over 0.1. And this is essentially a very good intermediate vision lens. And as you can see, as the defocus increases, the average logmark significantly drops off. So I think as we are going along, more and more than the near vision, it's the intermediate vision that's becoming important. We are not going to the books or the newspapers of our information. It's tablets. It's basically even these webinars are using these computers and screens, and driving, including night driving, looking at the dashboard of a car, reading price tags when shopping, watching TV, including reading subtitles. What you do at home and what you do for your recreation is almost all intermediate vision. And it's irrespective of the age of the patient, even for a 70-year-old, that's what matters. So that's the reason that I believe that these intermediate vision lenses are extremely important as a lifestyle lens. As far as our indications for these intraocular lenses is concerned, when a patient is looking for multifocality, comfortable vision for near vision, this is definite no-no as far as this patient is concerned. Basically, now my clinic, the patient comes to me after having been counseled for cataract surgery, after having been given different options. When I find that the patient is interested in multifocality, but he's an active person who wants to drive in the night time, doesn't have much reading requirement, this is the lens I recommend to him. Again, if the patient is interested in multifocality, but at the same time is constantly worried about the dysphotopsia, which we always make it a point to tell them when we talk about multifocality, I think that this type A personality is not fit for a multifocal intraocular lens, and moving away to a compromised lens like this, which is a eye-enhanced lens. Again, there are certain situations like a glaucomatous patient, a dry eye ARMD, a patient who is post-refractive surgery, who might be very much interested in multifocal intraocular lenses, but by virtue of the nature of the eye, may not be an ideal candidate for a multifocal intraocular lens. But if a patient is fit for a monofocal intraocular lens, that patient can have the advantage of an eye-enhanced lens and enjoy good intermediate vision. So essentially, to summarize, the eye-enhanced is a modern or a super monofocal intraocular lens. It's essentially an upgrade on the monofocal intraocular lens, not a replacement for multifocal intraocular lens. It's more likely to you are likely to hit uncorrected distant visual acuity of a 20 by 20, even if you have small residual refractive errors of minus 0.5 diopters or plus 0.5 diopters or small astigmatism, simply because it has a much broader landing area. And in case if you have a refractive inaccuracy, as I alluded to you, in spite of this, the intermediate or the distant visual acuity is not affected. The dysphotopsia is comparable to monofocal intraocular lenses, and essentially we counsel it as an improved monofocal intraocular lens. And because of the cost being also not considerably higher than a monofocal intraocular lens, we find that the adaptation for these lenses is constantly on the rise. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. It was a wonderful insight onto the new super monofocal lens, which gives a clear distance vision without dysphotoptic problems, and good intermediate vision with these lenses. I think the future would be, these type of lenses which can give you a multifocality of some sort without giving photooptic symptoms. I think that is what is required for a good optical quality lenses. Any comments from the panel experts sitting here?
I have a question for Dr. Ramamurthy.
Sure, sir.
Yeah.
In such a patient, suppose they have a reading problems, and then optical correction can be given. Will that be well tolerated by the patient?
Absolutely. Even the counseling bit, we always tell them that for serious reading, you would require glasses. So only thing is, most often spectacle dependence is gone. So if the patient, most often they are not able to read comfortably, and then we just prescribe them readers. Maybe it could be a progressive lenses, or it might be just a plus 1.5 diopter lenses, which they can go back and use as and when they require to read. But the spectacle dependence is largely done away with.
Dr. Ramamurthy, can you please stop sharing the
I
thing?
think, I'm sorry. Yeah.
No, it's not. It's not.
Sir,
The
now,
green
Murthy sir,
button,
there is one question from me.
green button which is there at the bottom.
Admin can do that.
No, so they will
No,
not.
no.
They will not be able to do it. Dr. Ramamurthy, green
Yeah,
button.
yeah, I've done it so often. Sorry.
Mix
Okay.
and match can be
Sorry.
done with monofocal, sir.
Sorry?
Mix and match can be done with monofocal, like Technics one piece and Technics eye hands.
See, it's always the dictum that, you put similar kind of lenses in both the eyes. And of late, I'm getting some patients who have had a Technics intraocular lens in one eye and now looking for some amount of intermediate vision. Discussing with them the limitations of such a combination, we go ahead and do them. On the other hand, there are also a few patients who have had a multifocal intraocular lens in one eye, not absolutely happy with it, and don't want a repeat of a multifocal intraocular lens. We go ahead and implant a eye-hands lens. Ideally, I would like to implant the same type of lens in both the eyes, but it's not. It's possible to implant this lens in the one eye alone, but it's not the mix and match concept that I employ. That is in the sense that try to steal a little bit of near vision aiming at minus 0.5 or 0.75 diopters. Because if you do that, then you lose visual acuity both for distance and intermediate. So essentially, it's a good intermediate vision lens, and the patient has to reconcile to the idea of wearing glasses for reading.
What about EDOF in one eye and this lens in the other eye? Have you done any cases like that, or would you be okay to do cases like that?
With the EDOF lenses, the patients are more often dissatisfied with the near vision acuity they have, and it's often the dysphotopsia is not really a problem. In these cases, I would rather put a EDOF lens in the second eye, aiming at a minus 0.5 or a minus 0.75 diopters, because this lens is again going to be inadequate for near. So I have had no occasion to combine this with the EDOF lens. But obviously, if the patient is very dissatisfied because of dysphotopsia with the EDOF lens, maybe I would not hesitate to use this lens.
So can I say something, Dr. Titia?
Sure, sir, sure.
So actually, the eye-hands lens is a replacement for a monofocal lens, wherein you don't have any dysphotopsia and there is no specific zones or anything that is being created. The good thing that J&J has done is that the cost of this lens is only marginally higher than a monofocal. While there is this lens that has been introduced by Alcon, not in India still, Vivita, I think that's the name, that is 4 times the cost of a monofocal lens. So I don't think that has been accepted well by the ophthalmological community overseas. But the eye-hands lens in my practice has cannibalized a lot of my monofocal lenses. I don't even tell the patient anything that I am putting a slightly different lens. When you are not putting, when you're not telling anything and you're not raising the patient is reasonably happy. And what we do in this lens is that we do a mini monovision. That if you have to do a monovision with a normal monofocal lens, you would want to have -1 or 1.5 to give anything worthwhile. So in this particular case, even if you do a myopia in the other eye of about 0.75, the patient has a good reading ability and there is no proper contrast. So I think it's a clever play by J&J, and people who have used eye hands are really happy soon become a replacement for a monofocal lens. That is my take. You can mix and match with others, but you really don't. You just do a monovision, a slight monovision with 2 eye hands in both the eyes. That it results. And apart from it being, it is also an achromatic lens, so that also gives us a good quality.
If the patients are reconciled to the fact that okay, I have to wear readers when I have to sit and read, Rest of the time, I have an uncompromised vision for both, even with monofocal lenses. In our experience, what we find is the patient requires about a 1.25, 1.5 doctors of VAT for reading. So rather than doing that kind of a titration in the second eye, I'd rather aim at emmetropia in both eyes, give them uncompromised distance and intermediate vision, and allow them to wear glasses for reading as and when required.
Okay, Ram, I didn't say mix and match at any point. I'm just saying that it is a slight overcorrection or getting a myopia in one. So non-dominant you can fix, dominant you can fix for distance, and if that is the first eye and the patient is happy with that, you can do the other eye with a minus 0.0 or 0.75. I am personally using a monovision, and ever since I have been got into the presbyopic age, I just stopped wearing my. So that's really a blessing, and you can loss of contrast. So see, when you are having a premium lens, which is a trifocal lens or a bifocal lens, in that where the split of the light is already there, if you have uncorrected residual power, that impacts the quality of vision there. But when you have a lens which is akin to a monofocal lens, a slight myopia does not impact it to that level. I do it routinely in my practice within the eye hands, overcorrecting eye by 0.5, 0.75, and the patients are brilliantly happy with that. So it's not mixing and matching with a
No, I understand your point.
or with a tri.
What about toric platform? Because
fortunately, the toric eye hands is still not available.
Because that's going to create the difficulties for our patients.
Yeah,
because that will take away all the advantages.
There are two problems. Even the synergy that they are launching is without a toric platform, and the eye hand that they have launched is without a toric platform. And we have emphasized it to them that torics are now the standard of care for anybody having an astigmatism more than say 1.25 or something like that. Should ideally be looking at doing a toric. So they need to get in a toric pretty fast.
Thank you, sir. Dr. Sucheta, we can go to a third speaker.
Sir, can I ask one question?
Yeah.
Oh, why not? You are the organizer.
I just wanted to know how is this enhanced if we do it in pediatric cases? So any take on the thing of older patient, can we go ahead and do it because you're saying monofocal is there and intermittent vision is still will be there? Can it be helpful in that way? Any take on this? Or any thought in the future to think about this lens in the pediatric age group?
I really don't know of any published literature, neither do I have much experience of doing it in a pediatric age group, but I have done it in a 30-year-old, etc. So I can't give a very qualified response to that, but logically thinking, I don't see any reason why it should not be used because it has no dysphotopsia symptoms. It's just a additional to monofocal lens. It might give a little intermediate vision. So I don't see any problem in using it. But having said that, more and more I've started using trifocal intraocular lenses in pediatric age group. I find that, and not in the 2 years and 3 years, but anyone above 5 years of age. I find that the neuroadaptation in these younger individuals is even better. And if you are able to, especially toric multifocals are also available, toric trifocals are available. If you are able to take care of everything, you are often able to get spectacle independence in these cases.
So I think
what about sensitivity, the issue of contrast sensitivity?
Sorry?
The contrast sensitivity in trifocals when you're using in kids.
No, with the modern trifocals that are available to us, I'm not saying that no patient ever complains of dysphotopsia, but definitely the incidence is less. But with the current technologies of cataract extraction, taking care of the cylinders and the other ocular surface, the current intraocular lenses, and neuroadaptation in the younger patients is always better than the older patients. So I find that majority of these patients do accept and do reasonably well. Whenever I have to prescribe a presbyopic glasses for say a 10-year-old or a 12-year-old, I think that's not something that's quite acceptable to me. And I believe that even if you put these eye-hands lenses in a young patient, he or she might still require reading glasses.
So the only thing, Dr. Sucheta, I'll wish to add is that this has the solidity and the long-term record of a Technis platform. The platform is the same, the material is the same, and we don't get any glistening or anything that we have ever observed in a Technis lens. The capsular C loop, etc., and the lack of PCO, etc., are the other advantages. So I am not going into the discussion of trifocal versus this, but from a perspective that it is a time-tested material that you are, it's got the the backbone is Technis.
Yes, so that is the only thing I was asking. Since it is a monofocal base, can we think of in pediatric?
Instead of putting a Technis one, which I normally like, you can go ahead and put an iHands. There is no problem in that.
Thank you.
And thank you. I think I'll just need to leave for another one. And pleasure being with all of you.
Thank you, sir.
Thank you, sir. It was lovely to have you, sir.
Thank you.
So we have our next speaker with us, Professor Namrata Sharma. Hello. Admin, please put the... Hello.
The slide is there.
Yeah. So we have Professor Namrata Sharma, who is a professor in cornea and cataract and refractive surgery at RT Center, AIIMS, New Delhi. She is the honorary general secretary of AIS, and her interest lies in phaco-LASIK corneal transplant surgery. She has numerous national and international awards and auditions, 380 research publications. She is the epitome of woman power and a dynamic personality. So over to you, madam, for your presentation on phacoemulsification and corneal transplant.
Thank you, Sucheta, for that kind introduction. At the outset, I would like to thank Dr. Sucheta and Professor Tritial sir for organizing this webinar on the AIIMS platform, and for all the topics which are very good. I'm sure it is going to be a great scientific deliberation. And I'm going to be talking about phacoemulsification and corneal transplantation. Now, there are no financial or proprietary interests, and there are several ways in which a cataract can be tackled in a case which requires corneal transplantation procedure. And sometimes you have to do simultaneous procedures, and sometimes you have to do sequential procedures. It is important. We've talked so much about intraocular lens just prior to my talk, but it is important that in these cases, we generally prefer to use a monofocal intraocular lens. It could be a sphere part or a toric, depending on the requirement. Generally, keratometry or video keratography is not possible, and we have to take a standard K. Axial length is something which is possible, and IOL master again is not possible in these cases. So for the calculation of the IOL power, one actually has to take other factors into consideration, like for instance in DSEC, there's going to be a hyperopic shift, so you have to aim for minus 1.25 diopters of myopia. And in cases of DMEC, again, there's going to be only slight shift, so likewise one has to change the power. You may have a case like this where there is cataract present and there is a corneal transplant which is there. And this is just to show in a full thickness corneal transplant, you may need to do toric intraocular lens implantation because these cases may have residual astigmatism. Preoperatively, it is important to ensure that there is only regular astigmatism present, because the toricity would take care of only the regular astigmatism and not the irregular astigmatism. And then the cataract, the phacoemulsification surgery is done very much in the same manner as you would do a routine surgery, taking into consideration that you have to use viscoat or you have to use dispersive viscoelastic to protect the graft. Prior to the graft, it is very important to do a specular microscopy examination so that you know that the endothelial cells are healthy. And then also the corneal thickness and the steps of the phacoemulsification surgery remain pretty much the same. And when you have a toric IOL, then you have to just put it into the axis which previously had been marked. And the eyes tend to have a little deeper anterior chamber, so one has to ensure that the lens is stable inside the bag. Now, you can have cases like this, white cataract. In this, the sutures have not been removed because the cataract developed very fast. So again, the IOL part calculation may be a little difficult and different here. And again, it is a white cataract, so the rhexis is being done, the phacoemulsification is being done, followed by the irrigation and aspiration. and foldable intraocular lens implantation. Notice the graft was at the level of the PK. It is so much, thinned out, and this can happen in some of the cases, depending upon the pathology of the host. And when you have a Fuchs dystrophy with cataract, the two things that you have to look at is the corneal thickness and the cells. So the figures are of 650 and 1000. So if the CCT is less than 650, cells are more than 1000, then you can do corneal transplantation alone. But if the visualization is poor, the corneal thickness is increased, the cells are less than 800, then you have to do a triple procedure, which could be a endothelial keratoplasty triple. And if there are no epithelial changes, then one can do a sequential procedure and see how it goes. Now, this is just to show that sometimes cases are there like this, chemical injuries with corneal transplants where white cataract has developed. And if you remove the planus, it becomes quite clear. So it can just proceed then like your normal surgery. In this case, again, the suture has not been removed because the cataract developed very fast immediately after the transplant, and this was a referred case from outside. Then you may have complex cases like this, a PUK where patch graft has been put and subsequently cataract is here. So cataract surgery has been done and the post-op visual acuity is fine. So these sequential multiple surgeries may be required. Now, at times, the spheroidal degeneration with healed keratitis where ALTK is being done. So again, the important thing is you would go just like as you would do normal cataract surgery, except for the fact that the irrigating solution has to be good to protect the endothelium, and also the viscoelastic has to be good. And sometimes when it does get blurry, you can put viscoelastic, especially when you're putting the foldable intraocular lens inside. And remember to wash away the viscoelastic which had been put previously. And if it is a ALTK, you have to put sutures, but if it is SALC, you may leave it sutureless. And this was a case, one-eyed patient for which chemical injury, a DALC was being planned. In fact, cataract was not planned in this case. And then subsequently, because the patient had issues of follow-up, also the cataract surgery was done at the same time, but you could also do it subsequently if the cataract is not mature. So in this case, the cataract surgery was done. The forming of the wounds becomes a little tricky because it just gives way because there's not enough of cornea over there. And then again, the lens is put in the bag. The last bit of the stromal tissue is then removed because you can't do phacoemulsification with the Descemet's membrane on, and subsequently the graft is then sutured. Now, this of course is a little complex for this, but this is a post-still case in which white cataract developed, and so a capsulorhexis was done. The capsulorhexis gave way a little bit, so it had to be cut to regularize it. And then the cataract is soft, so this has been emulsified and followed by the irrigation aspiration and a foldable intraocular lens implantation. And you think that nothing would happen to the graft, but if you have an intraop OCT microscope, you realize that there is a little bit of graft which has moved from its place, and then that has to be adequately addressed in the post-op period, and you have to ensure when you leave the chamber behind that the graft is that there's no gap between the overlying graft as well as the recipient bed. Now, this is of course a case, Fuchs dystrophy, which is very much advanced, where epitheliorhexis followed by the descemetorhexis is being done, and then anterior capsulorhexis is being done. Now, all this has to be a little intuitive because you can hardly see anything. And it doesn't matter if you phaco towards the corneal side because you're anyway going to replace the endothelium, but it is important that you don't have a PCR in such cases because that can be a disaster. So this is with the Busen's glide, the graft is being put there, and then air bubble is instilled, followed by the centration of the graft. And this is now 3 years, 4 years down the line with a clear graft. And then of course the DMEC, which is the most physiological graft. This is a case in which Fuchs dystrophy with cataract was present, and this has been removed. The cataract surgery has been done. Now, after doing the cataract surgery, you have to do a DMEC. So this is the area which is being marked from wherein the Descemet's membrane would be removed. And this is followed by the removal of the diseased Descemet's membrane. And this is the physiological Descemet's membrane roll which is taken and which is placed inside the anterior chamber. This is the wrong side up. When it gets to the correct side, which is the biceps curl upwards, you just put air bubbles. And this is the top picture, month 1. You cannot make out that there was a graft there. Now again, I think this is complex, but this is a case of a post PK DSEC cataract, which is again a white cataract. So PK was done first, the endothelium failed, so DSEC was done. Now there's a white cataract which is present. So this is just to show a very simple message which I want to give here, is that sometimes when you have such complex situation, if you have an intraopacity microscope, you know at what stage the graft is, detaching, and then adequately and intraoperatively those measures. See, you can see that the graft is moving a little bit here as you put the intraocular lens inside, and just at the end you ensure that the graft, the BSEC graft, is attached to the host. Now, just to show the algorithm that we published in the case of cataract surgery with corneal opacity, so I want you to pay attention to this last part, where each of the procedures that I've shown you have been described, and this is there in our review article which was published in JCRS. So thank you very much for your kind attention.
Thank you, Dr. Namrata. Wonderful videos, classical demonstration of surgical steps in those cases. Any comments, Dr. Tushar? Okay, he's not available just now. Rajesh?
Yeah, I mean, these are wonderful videos, and these are wonderful demonstration of how a corneal pathology and cataract can be handled together. So, and I think.
Yeah, Tushar, you have some, interest in these cases. Any comments?
Sir, I think for the audience sake, I'd like Dr. Namrata's opinion, because most people wouldn't have access to intraoperative OCT. So any this thing about you've been using a lot of endoilluminators to increase the visibility during cataract surgery in corneal pathologies.
Illuminators can be used. That is a good trick to do, especially when it gets a little bit hazy. Those can be used. They are good tools. People have even used chandeliers. I'm sure Dr. Rajesh has used chandeliers in presence of corneal haze. Again, that also shows well. Of course, you have IOCT. I'm not saying it's only that it fine-tunes your steps a little bit, but even if you don't have it, there are clues even clinically and otherwise to, except in very subtle cases. It just helps you to be sure intraoperatively.
And one thing which I've noted is that it's the discrete and the more dense opacities are actually easier to handle during cataract surgery. It is the nebulomacular hazy corneas which are more difficult to handle during simultaneous phaco in these opacities. So sometimes one might get tricked that, okay, this opacity is little less dense, so it would be easier, but it's mostly, I think it is opposite. The discrete opacities leave the rest of the cornea clear, but the hazy corneas I have found that are more difficult to handle as far as phaco is concerned.
It also depends on the location of the opacity. Like if it's dense opacity at one location, you can slightly modify.
Change your, yes.
Also, like even we had a paper, Dr. Namrata had suggested doing an eccentric crater in that, if you remember that.
Mm-hmm.
And then we also had a paper, Professor Titial knows about that, if you have a opacity and a cataract, then you can do a cataract surgery and then do a small sphincterotomy to improve the visual acuity without doing any keratoplasty, particularly in one-eyed individuals wherein you want a long-term reasonably. So
the other thing is that any case with a significant corneal pathology, I normally like to first, before starting the actual case, I'd like to just place the microscope over the patient's eye and then assess the area which is opaque and the area which is clear to me. And then and then sort of do a dry run on the cornea. I mean, just see whether where my instruments are going to land, especially the phaco tip and the chopper, and then adjust the microscope accordingly. So that the idea is that the whatever clear area you have available should be right opposite to your hand rather than going on top of it. So even if you have to place your incision eccentrically, not in a normal area, it always helps rather than starting the case and then realizing that you are actually obscuring the whatever clear area that is available. So that's a good trick I found to do such cases.
Thank you, Tushar. Thank you, Dr. Namrata. Wonderful presentation. I think that what Tushar has highlighted, microscope, I normally would advise all our students, don't go with the slit lamp, view, because that gives a section through. So you can see the eye on the diffuse light or slit lamp. That also gives you how clear is the entry chamber structures. But yes, we do see such cases in our scenario. I think Dr. Kavita will cover those, cases where you have a difficulty being maybe SICS type of surgery. People might prefer sometimes, But whatever surgery done, phaco is much more comfortable sometimes. Thank you. I think we can shift to the next speakers. We have had, the you can say mega players, the openers. 3 openers have done. Now middle order and tail enders will take away the responsibility of this webinar now.
Thank you, Madam Namrata, Madam, for this wonderful thing.
Thank you.
Ma'am, just one question. What is your take? Children, they have a lot of trauma and they come with corneal opacities. So how do we tackle the cataract and opacity? So how do we go about? Any tips in those cases? Just a concluding remark before you go. So
I think Tushar has beautifully highlighted, and I know that he has a thesis on perforating corneal injuries in children, whether to do cataract at the same time and to do cataract at a later date. That itself, is a question that needs to be sorted out. But if there's a corneal opacity which is present with a cataract and it's a opacity, it's not a scar, it's not a fresh injury, then I think in all those cases one has to, it is important that always preferable that you put an intraocular lens, but even if you don't put it is okay, because there would be some irregular astigmatism that would be there related to the scar. So that probably can be corrected even with the contact lens. And I think it is important to know how much of that is contributed by the scar itself and how much you can correct with the IOL. And again, all the caveats of any case where you have a cataract and a corneal opacity will have to be followed in children also.
thank you. So next, we will go to the basics again after having a very dynamic interaction with all the advanced technologies. So we have with us Professor Kavita Bhatnagar. She is the professor and head of AIMS Jodhpur. She started her career as a captain in Indian Army and her specialty is in anterior segment and glaucoma. She did her MBA from Symbiosis Pune and she's a passionate teacher and medical educationist. And she is the former founder of ACON Rajasthan State Chapter. Over to you, madam, to speak on transition from small incision to phaco, the need of the hour. Kavita, madam, please.
Ma'am, you unmute yourself.
Madam, please unmute.
Yeah, it's okay?
Yeah.
Yeah. Okay. Are the slides visible?
No. You have to share the slides. Share screen.
It's visible now?
Yes, it is.
Madam, go full screen.
It's full screen now? Yeah. Okay. A very good evening to all. At the outset, I would like to thank Professor Titian and Dr. Sucheta for organizing such a wonderful webinar for all aims. The topic given to me is transition from SICS to FACO, need of hour, which indeed is. I have no financial interest whatsoever. No offenses, as both FACO and SICS have their advantages and disadvantages. The layout of my presentation is going to be like this. We all know cataract is the leading cause of blindness worldwide, with removal of cataractous lens and implantation of IOL being the treatment of choice. Goals of modern cataract surgery are rapid patient mobilization, minimal induced astigmatism, and early visual rehabilitation. Two techniques which meet these criteria are SICS and FACO. FACO is the preferred technique in developed world and tertiary centers of developing countries. Numerous randomized controlled clinical trials have proved it to be safe and effective for rehabilitating the vision of cataract patients with obvious advantages. An ultrasonic probe is used to emulsify the cataractous crystalline lens and debris aspirated with high vacuum and foldable IOL implanted in a FACO. While in manual SICS, entire crystalline lens is removed through a self-sealing scleral tunnel incision about 5 to 7 millimeter, and rigid PMMA IOL is implanted. Many studies have compared these two types of surgeries with these outcome parameters. The first trial comparing modern SICS with FACO on 400 randomized eyes randomized to each technique was conducted by Gopte et al. At HV Desai Eye Hospital, Pune, and they found that at 1 week, 68% of FACO eyes and 61% of SICS eyes had UCVA of at least 618, which improved to 81% for FACO and 71% for SICS at week 6. One of the criticisms of this analysis was that surgeons may not have been equally skilled in both techniques. So a study was therefore created following expertise-based trial design. Ruet et al. In Nepal conducted a study on 108 consecutive eyes randomized to FACO or SICS. All surgeries were performed by an expert in the technique, and they concluded that each technique achieved reasonable outcomes with few complications. Now, as far as astigmatism is concerned, mode of astigmatism was 0.5 diopter for FACO group and 1.5 diopter for SICS group in study by Gopte et al. And study by Kane Hayashi also found similar results, where he used 2 mm incision and 2.65 mm incision with FACO, and surgically induced astigmatism was still lesser in 2 mm micro incision. Corneal endothelial cell loss, well, some studies say there is higher loss with FACO and others say there is no difference based on meta-analysis. PC compromise in study by Gopte et al. It was 6% with SICS and 3.5% with FACO. Other studies also found similar results. As far as CME is concerned, even OCT based, there was no difference between the two techniques. A 2009 publication by Ravindran et al., they reviewed all cataract surgeries performed in an 18-month period at Arvind Eye Hospital, and they found that SICS group developed end-off in first 3 months at a rate of 0.11%, while FACO, it was only 0.03%. Well, the rate of capsular compromise rises in cases with pseudoexfoliation, weak zonules, small pupil, phacodonesis, regardless of technique. However, SICS may place added stress on the zonules when you're tumbling the nucleus into the anterior chamber, and a small pupil may hinder nucleus prolapse. Cost comparison, the cost effectiveness of FACO comes from its ability to return patients to work and to their functioning lives more quickly than conventional surgery, even though the total cost for phaco is much more than SICS. Technological advancements. Since the introduction of phaco technique, phaco machines have undergone numerous upgrades and modifications which have improved the efficacy and safety of cataract surgery. Modifications in the phaco probe tip has led to easier emulsification of cataracts with less dissipation of energy, which causes reduced corneal endothelial damage, ultimately minimizing the post-operative corneal haze. New phaco machines offer advanced fluidics with balanced aspiration flow rates. It causes minimal fluctuation in AC parameters, maintains dynamic IOP control, avoids surge leading to faster visual recovery, and decreases damage to AC structures and risk of PC rupture with vitreous loss. We are currently in an era of premium IOS with features which aims to meet the ever-rising patient expectations, and micro-incision phaco technique with rollable and injectable IOS which have minimal surgical induced helps to achieve desired uncorrected visual acuity, and patients have options for IOS beyond anyone's imagination. To summarize, advantages of phaco: it can be done through a very small incision. There is early rehabilitation, good UCVA, and can be performed under topical anesthesia. There are less because it can be performed in the posterior chamber. There is no need to prolapse nucleus into the anterior chamber, and there is minimal post-operative astigmatism. But at the same time, there are disadvantages that it is machine-dependent technique, high financial investment, longer surgery time, longer learning curve, and it requires constant reliable power, good equipment maintenance and service of spare parts, and it may not be suitable for cataracts. Now, SICS also has its share of advantages and disadvantages. Advantages are it's a high quality, high volume, low cost cataract surgery, so best suited for camps. There is good rehabilitation, shorter learning curve. Its universal applicability to for all types of cataracts and even with compromised. It is applicable for remote areas, can be performed with relatively inexpensive microscope. Disadvantages are surgical skill and expertise of surgeon plays a significant role in the result, which for all surgeries it does, and surgically induced astigmatism is more because of longer incision size, and intraop complications may be more. The best or most important thing to have is surgeon's skills, whatever type of surgery you perform. So, the choice or whether you want to drive a Tesla or Mercedes or BMW also depends upon so many factors, including the terrain. So is cataract surgery. So a cataract surgeon should have both SICS and phaco in his cataract surgery armamentarium, and PG should be trained in phaco also once they have mastered SICS. Thank you very much for a patient hearing. Thank you.
Thank you, Professor Kavita, putting the point across people who are logged in today. We all understand, in India, the largest number of surgery for cataract is SICS. And that is how we get the numbers. And today it's a need of hour of entire country to have surgery which can be for masses. SICS, the results has been very good in last so many years. It is as good as phaco in these peripheral areas. Both have advantages, both have disadvantages. Ultimate is the outcome, and outcome is grossly not different. In that way, I think you are right. People should learn both the techniques, and it depends where exactly their techniques or their expertise required to do these surgery for our countrymen. So that is important. I understand both surgeries are actually good for our cataract removal. I think we can discuss subsequently as the basics of surgery will come. Dr.
Thank you,
Sucheta,
sir.
can we go to the next speaker, please?
Admin, please put the next speaker, Professor Soman Mishra. So we have our next speaker, Professor Soman Mishra, who is the HOD of AIMS Raipur. He has many awards to his credit, some of them being Dr. V.C. Chitnis Award. And he has 51 peer-reviewed research publications. He is a guide to 19 students. He has a lot of experience in teaching, around 27 years. And he has been also given the Best Teachers Award from Maharashtra Ophthalmic Society. So over to you, sir, for your presentation on biometry, current best formula for all eyes. Professor Soman, sir.
Thank you, Dr. Sucheta, for organizing this webinar, for taking all new aims and including the mother aims, the daily aims. And thank you, TTL sir, for coming and joining with us and also giving us support, because we are just beginning. We have just started and we need somebody mentor like you, and you have rightly come and Dr. Sucheta has invited you. With these few words, let me start with the biometry. My topic is current best formula for all eyes. First of all, let me tell you, this research is going on for the last 40 years or more than 40 years. And you are still trying to find out what is the best formula. As such, there is no best formula for all eyes. All eyes cannot be calculated with one formula. So there are some variations, but yes, over the last 40 years, people are working on it. And it is evolving, and we are close to the goal, like N6, but not at the goal. We are close to the goal, but not reached completely. So with these few words, I'll start my presentation. To have the biometry, we need the three basic parameters. One is axial length, keratometry, and anterior chamber. And of course, the IOL formulas are different, and the clinical variables, because all of you know, probably all eyes are never same, rather two eyes also of the same person are not same. So these clinical variables are also very important to decide or to find out the actual power of the eye. So these three things which decide the IOL power calculation, biometry, IOL formulas, and clinical variables. Ophthalmic biometry. Biometry means many of our residents as I presume that most of the listeners today are years and years, maybe many more. But what is biometry? Biometry is the measurement of distance in living tissue. If it is in a cadaver, it is not biometry. So biometry is the measurement of living tissue. That I again tell you. Ophthalmic biometry is measurement related to the eye, obviously, different, mainly the globe. Of course, there are little other parameters, so mainly we'll include our discussion the globe. So there are two types of biometries. One is ultrasonic biometry, that is scan, which is age old or rather since long. And later on, when people found that there is some refractive surprises, it's not very accurate, it's not N6 all the time. So people thought of if we can have better things. So obviously the light has more precision over sound, that all of us know. So people thought of if we can go for the optical biometry, people started trying it. But the main problem, if TTL sir can confirm, that when we started our cataract surgery, maybe 33 years back, most of our surgeries where patients were used to white cataracts or the brown cataracts, is all mature cataracts, but it is not so. So those days, ultrasound was the main way to calculate the biometry. Later on, when we moved of operating much immature cataract patients, or maybe today of 6'9", 6'12" patients, space eyes are media is clear. So we had one advantage, rather we have today, that we can use the precision of light, and that is the way biometry shifted from ultrasound to optical. That is a brief way how it has moved from ultrasound to optical. This is some basics of ultrasonic biometry. How the distance is measured, the velocity of the sound and the time, and how the distance is calculated. This is a schematic slide. How we calculate the distance or the measurement, the distance of the globe from the cornea to the retina. Optical biometry, when it evolved from ultrasonic to optical, of course, obviously not in the white cataracts or in the brown cataracts where light cannot penetrate, we started using people started using the partial coherence interferometry or PCI. This is a spatial technology which makes possible sort of OCT, not exactly OCT, but sort of OCT, which needs some transparency in the cataract, and so that it reaches the retina and can give more precision in comparison to ultrasonic. It is obviously it is mentioned that it is highly accurate, and obviously it has one advantage, that it is non-contact, more complicated. So gradually with time we are moving from ultrasonic biometry to optical biometry. Maybe from 10 years now, probably all biometry will be optical. This is as my topic is the best formula for all eyes. So let me tell you the range where most of the formulas work, the extremes of myopes or hypermetropes or other extremes, all formula doesn't work. So this is one example where the ranges are mentioned. So if it is 39 to 47, like the keratometry, all of you know, when the lens power is from this to this, like 15 to 23, when antechamber depth is 0.5 to 4.2, or axial length is 20 to 26. This one I am to specify extreme myopic eyes or extreme hypermetric eyes. There is no formula which actually works. Still, we are evolving, and we have come to a formula until where it can work with a wide range, but not very extreme, below 22 or above 26. How the biometry has evolved, obviously the first generation no more in clinical use as of today. Second generation, maybe somebody is using, but practically maybe remote places, but practically second generation has gone. Now, as of today, either we are using third generation or fourth generation, or obviously both sometime to compare. So either third generation SLK2 or SLK3, holiday 1. And interestingly, it has evolved, as I have already mentioned, last 40 years. And we are presently dealing with fourth generation most of the places, because it's not very difficult other than having an optical biometry. So fourth generation, holiday 2 or Agis formula, these two are quite good. Rather, what Dr. Sukraj asked me, that for all eyes, almost all eyes are covered, maybe around 99 to 90, 98 to 99% can be covered with fourth generation. First generation, how it has evolved, depend on the single constant. You all know, I think most of you, rather those who are senior, has gone through this formula, at this SRK, all of us. Remember when we started our residency more than 30 years back, 30 to 33 years back, SRK1 was the only formula. Then it evolved to second generation, that is SRK2, and obviously the Hoffer's formula. But nowadays, more or less, they are not no more in clinical use. We have gone to third and fourth generation formula. This is the third generation formula. where, like one thing let me tell you, why it really did not work. Why we have to move from first to second, second to third, third to fourth generation. Because surgeons noticed that after 6 weeks or maybe more than that, there is some residual refractive error. Little unexpected amount of astigmatism. So people started thinking where we have missed, what we have not calculated. At one time, even 30 years back, I thought that only axial length and keratometry is good enough. Later on, people all over the world started working on it and found that anterior chamber depth is important. Lens thickness is important. There is an important factor of every person, every surgeon, all surgeons are not the same. We are not doing yet the robotic surgery. So the surgeon's parameter has come. The anterior chamber depth parameter has come. The lens thickness parameters have come. That way, and also this white to white means corneal diameter, one side of the other side of the sclera. These factors, including patient's age, which has been incorporated in the newer formulas, where at the beginning we were dealing with only axial length and keratometry. So these formulas helped us to evolve more and more, becoming close to our aim, that is N6. And almost we are close to our goal, not at the goal. That is fourth generation formula are being used, I already mentioned, Agis or already. Now, this is a schematic slide which mentions why, what has evolved, how we never, I myself, 30 years back, never thought that anterior chamber depth will play a role. I never thought that white to white distance will play a role. And even today, if we ask a resident, he or she will say that why lens thickness? Because you are removing the lens, by the way. You just capsule your lens. Why you want to calculate the lens thickness? But with time, we have come to know that these are very important parameters to be accurate or to reach the goal, like lens thickness, white to white, and anterior chamber depth. These were never considered in the initial form. And the way it has evolved from holiday 1 to Hoffer 2, SRK T and Haggis, and presently holiday 2. What I want to stress over here, more and more variables you include, it becomes more and more accurate. That is one thing. And the last slide, the last line, that is holiday 2 shows that so many variables have been taken. This is how to choose. This is a schematic slide where you can decide, depending on the axial length, which formula will be best. Like as I have told at the beginning, there is no straight cut answer to one formula. So depending on the axial length, you use the different formulas. And this is the slide. Obviously, I have told repeatedly that all formulas will not work for all eyes. That obviously sure. If you take this, this is the normal axial length, how different formulas work. This is holiday 1, which works in the extreme range of, wide range of myopias. This is Hoffer Q, which works partly in myopia, partly in hypermetropia, but taking both into account. This is SRK3, of course, normal range, all formulas work. Obviously, that is the way the formulas have come. Here in SRK-T, it works mainly in the myopic range, other than normal range. And Heidi's formula, which works quite wide, both hypermetropic and myopic spectrum. But it needs all A constants. Many a time for the resident, for somebody who is calculating, I'm sure probably none of us are calculating our formulas, maybe our optometrists or residents are calculating. So all before you decide the highest formula, you need all the A constants. These are 3 A constants. One is A0, A1, and A2. All 3 constant. You want to plan surgery tomorrow, and sometimes you do not get those all the 3A constant from the company. So that becomes a little difficult for high risk formula. That is why the last, another most default formula is probably as of today is holiday 2, which has a wider spectrum, extreme of hypermetropia, extreme of myopia, and obviously the normal one. So in one word or one sentence, if I am to answer that what Dr. Sucheta has given nicely one topic, that one formula which is for all eyes, almost 99% will be covered by holiday 2 without knowing much of the across. That's it. This is the last slide which I'll tell. Other than these variables, you keep some special cases where obviously the silicon fill eyes, the post-penetrating keratoplasty eyes, post-lamellar corneal surgery, whether DSEK, DLEK, or the LASIK, whatever, any lamellar surgeries of the eye, or any posterior subclavian of the extreme myopia. These 4 clinical conditions where you must think twice or think of a special formula or a very suitable formula, which obviously time is less. I'm not going to that. So these are the 4 special clinical have to think. Otherwise, in one sentence, my topic is covered with holiday 2, which is very wide range covering formulas, and which will cover both extreme myopia, hypermetropia, taking all the variables without much of knowing much of makeup. That's all for today. Thank you.
Thank you, Soman sir. Nicely described entire, IOL power calculation. Difficult to summarize all of them together. We do have newer generation formulas which can give you a lot of good access to various length of eyes, right from small to long eyes. But it depends how effectively a particular clinic does these biometry workup and the post-op results of your cases. That also a huge impact onto the clinical practice. Dr. Sanjeev, which method of excellent measurement you are regularly doing?
Mostly the SR kit.
No. What I'm asking is, are you still doing a contact biometry or a immersion or optical?
No. We are using optical.
Okay, I think that's the advantage of AIMS. I think all of AIMS has an optical biometry. That gives you access to all types of formulas. And the newer formulas also, like Barrett formulas, which gives you, utility for all types of cases, right from the post-refractive to any type. Tushar, any comments on a biometry part?
Sir, I think the newer Barrett's formula, the universal formula, I think is also doing quite well in our hands. And as you said that it's the coordination between as I'm sure will be happening in all AIMS, especially that the optometrists, there is a optometrists who are doing the biometry and you are getting the results. Mm-hmm. So one has to track one's own results irrespective of the formula. I think that is the most critical element of the chain, in practically speaking, in our hands. Because the difference is within adapter. If you look at the IOL master sheet, the difference is not that much with most axial lens, if you exclude the extreme axial lens. So it's in your hand. I mean, what formula is working in your hands, and how well you are coordinating with the person who is doing the biometry, and whether the person is getting back to you, puts a little more effort in the job, and gets back that, sir, okay, there is some discrepancy, or I have called the patient again. I think that those small things make a much more difference than the formula, because with the optical biometry, I think most of the factors relating to the biometry itself have been taken care of. Yeah, and with the Barrett's formula, the universal formula, I think most of the extreme cases are also covered very well.
Okay, thank you, Tushar. I think nowadays the practice for most people, if the patient comes to you, if you feel patient would have cataract, the first thing they get it done is a optical biometry, which gives you both corneal findings and excellent. Then subsequently they'll examine the patient. So that has become a norm nowadays to have a absolutely virgin eye for all these parameters. Because sometimes if you play with the epithelium with your drops, other things, that can induce astigmatism and you unnecessarily will look for other things. So that's a, I think, very important way of looking your cataract patient. So if you've done dilatation, something that you may call patient next time to do a biometry for these patients. Any questions from the panel?
Yeah, so one question is there, like which exact formula or how do we go about with a 40-year-old lady who is presenting with cataract and he's had a LASIK surgery done with no records. So just how do we go about, can you just throw some insight? That is the question which has come up, sir.
Okay. I think as far as LASIK is concerned nowadays, in today's era, it's not a difficult proposition now. We are not looking for any past records because all these newer formulas can, do a good calculation without those records also. And formulas like Haig's formula for Haig's L myopic would be the best formula in these cases, or you can go Barrett's refractive suite, which can also give you the calculation in these patients. So these are two good formulas which can be used in these patients. And don't worry about what was the power, what was the pre-op K or a post-op K, the old contact lens devices, because we understand after refractive surgery, let it be RK or a LASIK or a PRK, it is the corneal parameter which is changing. So that is what has to be taken care of. Otherwise, now with new formulas, it covers the posterior corneal curvature. If you look into Newell IL Master 700, it gives you a TK value. So it takes away everything. You don't have to think what is anterior posterior in these cases. So that's the advantage now.
If someone doesn't have access to optical biometry and these newer generation formulas, and they still have to operate, then anything for them, like if someone is doing like a video keratography and an axial length.
So if it is a PRK or a radial keratotomy, the anterior surface changes much more than a posterior curvature. There, simply looking for an anterior curvature can be taken care of, and the factor for compensating the corneal curvature is there. So that is, it has to be looked after. But if you're doing a LASIK for a more than 6 diopter myopia, there is a definite change in the posterior corneal curvature in these cases. The base curve of posterior curvature changes. There you have to take instrument which can give you a posterior corneal curvature also. So I would consider a pentacam type of instrument would be better, which gives both anterior posterior corneal curvature, then do a calculation subsequently.
But in the past, I remember that when we did not have access to all these things, the
formula
way we were doing was that when you take video keratography and anterior surface, because most of these, you have to see that in post-refractive surgery, if you just blankly apply the formula SRK2 or something, you will basically undercorrect the patient. So I don't know. I will ask sir that we were adding 30% to the K. So whatever we were getting on video keratography, we were adding 30% value to that, and then to the power. So if you were getting, for example, 15 diopters, we were putting 4.5 more. So that was one sort of thumb rule which we were following.
Yeah, that was a gross way of calculating, but even that was quite effective in those days. And always are towards the myopic side for a calculation. And if you are taking a keratometry reading in these cases by 2-3 instruments, always are towards the flattest K from the instruments you have taken. And for IOL power, always go for the higher power. So that is a big norms for a post-refractive surgery corrections. Okay.
And challenge, sir, can be if patient had posterior staphyloma. So there the axial length may be, the getting correct axial length may be challenging. So those cases, yes, you may do extra B scan and, do AB.
Perfectly correct, ma'am. Their B scan will be handy, and you can exclude the staphyloma in those cases. And you know that is not the actual axial length, and that is very effective in such a way. So what we are discussing is not only the your only calculation. Entirety of eye and patient has to be looked into, and that is how you're going to get a best result out of these patients. Okay, I think we had a very nice discussion on it, very good presentation. Let's go to the next speaker, Dr. Sucheta.
Yeah, next speaker is Professor Sanjeev Mittal. He is the professor and HOD of AIMS Rishikesh. His special field of interest is cataract, glaucoma, and comprehensive ophthalmology. He has undertaken research projects, completed around 7 research publications of 59 book chapters, and he has a rich teaching experience of 24 years. So over to you, Sanjeev sir, to talk on the topic that is art of capsulorhexis and hydrodissection procedures for a safe phaco, which is the most integral part of any cataract surgery.
Thank you, Dr. Sucheta. Thank you, Dr. Sucheta. Am I audible?
Yes, sir.
Yes, yes.
Thank you, Dr. Sucheta, for bringing all the newer aims on common platform along with the RP Center. And I must thank Professor Titial, Professor Namrata Sharma, Professor Rajesh Sinha, Dr. Tushar Agarwal, and all AIMS Delhi's faculty. They are our mentor institution, and they provide unconditional support to us. Thank you very much. So the topic is the art of capsulorhexis and hydro procedures to facilitate safe phacoemulsification. Just a moment, there is something like the slide is not moving.
Dr. Sanjeev, just click on the deck and yeah, it will move now.
Okay. Yeah, continuous curvilinear capsulorhexis is the essential and crucial step in phacoemulsification surgery. It leads to a tough anterior capsular opening, which thus stabilizes IOL, which remains well in place. And this technique was introduced by Gimbel and Yuhan. This is just a diagram just taken from Fishkind book, just to show that the anterior capsule has attachments of granules at the peripheral part also, which are extended up to 2 millimeters. So while we are making capsulorhexis, we have to be careful. These are the instruments which are used for capsulorhexis: cystotome, and this is a Utrata forceps or capsulorhexis forceps, or MICS forceps, a femtosecond laser assisted, like Dr. Manipal Sajdeva has shown that. Radio frequency ablations are the tools which can be used. This is just to make a cystotome, a 26 gauge needle. We make a twist at 90 degree angle at the tip, and at the base in the opposite direction 120 degree is made to convert a 26 gauge needle into a cystotome. So to start with the continuous curvilinear capsulorhexis, the magnification of the operating microscope should be higher. We should ensure that the iris lens diaphragm is parallel to the ground, and the side port of the incision should be used for this maneuver. Trypan blue dye to stain anterior capsule may be used in case the visibility is not good, or like in hard cataracts, it can be used. And the meticulous use of viscodispersive viscoelastic substances should be done as and when required. We must avoid undue pressure on the eyeball. This is like how we do anterior capsulorhexis. We make a linear incision from the center and extend to the mid periphery just short of the diameter of the desired capsulorhexis. Raise a flap, triangular flap. Start making into circular fashion with a tearing force, and all throughout 360 degree. We make a capsulorhexis, the cap flap in the anterior capsule. So this is how we raise the flap in the anterior capsule. We may use the forceps as well. we raised a flap in the center, and the forceps can be used to make and we use a shearing force to make an anterior capsular flap to make it. So we use the stretching and the shearing forces with the use of cystotome or the forceps to make a perfect capsulorhexis. The sizing of the rhexis is very important. The ideal one is 5.5 millimeter, because if it is a correctly sized rhexis, it will have some overlap over the anterior surface of the IOL which is placed, and that all throughout cover of the IOL will prevent IOL tilt, will prevent IOL optic decentration, the myopic shift, other complications which may otherwise happen, the prevalence of PCO and the shrink wrap effect all are declined. And what are the tricks to assist in sizing of the rhexis? Like for the beginners in the starting phase, like we may use a corneal impression we make a ring caliper, or in some good microscopes, and we have an attachment or project through an interface module like Callisto and Virion, which one can take the help of that. So there are certain complications which may occur, and how to take care of that. Like the rhexis, if it goes peripheral, then it may lead to jonular rupture, it may lead to posterior capsular rent, it may lead to vitreous prolapse, nucleus may drop, and even after IOL, this posterior IOL dislocation may occur. So the solution to this is, the moment we feel like it is extending to periphery, we must use cohesive viscoelastic and use forceps to bring it back. Here we may use even the micro forceps as well to bring it back to the center. If there is an inadvertent radial tear and we are not sure whether it had extended to the periphery at the equator, then the other way is to tackle is must use scissors to start in the opposite direction, or we can either convert to the can opener technique, then conversion to ECC, all are depending upon the status of the complication or that which has occurred. Or in case we are continuing with the phacoemulsification, then we make the second opposite direction capsulorhexis and debulk the lens by sculpting before hydrodissection, because we have to be very careful for next step in these cases. If the rhexis is too small, we have to be careful, because what may happen, like sometimes like the rhexis is small, we are doing hydrodissection procedures that may lead to PCR as well. So what we do, we actually either again we repeat that, we double rhexis, we enlarge it, or after placing the IOL we can enlarge that. If the rhexis is too big, means more than 5.5 or 6 millimeter, so that is not an issue. But only thing is that at the end of the surgery, we must ensure that the posterior vitreous thrush is not much, and so that like there should not be any chance of pupillary capture. And if required, if we anticipate, we must use intracameral miotic after we have implanted IOL. In case the reflex is red reflex of the fundal glow is poor, maybe like in hard cataracts, so then the trypan blue dye should be used. And we should use air before injecting trypan blue dye. In hypermature or intumescent cataracts, there are certain problems. The problem is like when it may extend to periphery, so the staining dyes should be used, and the cohesive OVDs should be used along with HPMC, double shell technique, or endodiatherapy devices can be used alternatively to make CCC. Or if the basic purpose is that the interlenticular pressure to be taken care. So anterior chamber pressure should be higher. Some people may prefer to use mannitol as well. Otherwise, two-stage capsulorhexis is another choice. Like the first capsulorhexis should be smaller, then it should be enlarged with the help of the forceps and completed. So that this prevents extension of capsulorhexis to the periphery. In subluxated lenses, the key features are that the starting point of capsulorhexis should be from the attached part of the zonules. And we should not aim a circular rhexis here. It should follow the outer contour of the lens. For the beginners, actually here, the practicing of capsulorhexis can be done with a transparent soft plastic wrap tied over the mouth of the vial of lignocaine. like we have been training the residents for the last several years with this technique. Alternatively, some people use half-boiled potato skin or tomato skin also. Now the hydrodissection and hydrodelineation, the next step. Hydrodissection is the separation of cortex from the adjacent cortex of the capsular bag. We take a 26 gauge cannula with tip, we take it beneath anterior capsular flap and inject the fluid BSS in a controlled manner, in a controlled, stable and slow manner, and so that the fluid wave goes posteriorly and then it segregates. And then you saw in this slide that we dialed the nucleus with the help we rotated the nucleus. So we injected the fluid between the capsule and the cortex, or in the layers of the cortex. These are another videos to show hydrodissection and nucleus rotation. After hydrodissection, we are using the same cannula, or we may use the Sinskey hook to rotate. When we do a hydrodelineation, like here we are doing it, we have a golden ring reflex formation. So that ensures that the endonucleus has been separated from the epinucleus. So the hydrodelineation part, like hydrodissection or hydrodelineation, in cases of posterior polar cataract, hydrodissection should be avoided. Hydrodelineation is the technique. Like how to do the hydrodelineation, like we just take the cannula underneath the capsule and over the nucleus, make a stroke, move backward and forward 2-3 times to create a track, and then we inject. So what complications can occur? Like inadequate cortical capsular bag separation may take place. And when we are going to rotate the nucleus, ensuring it, we have to be very careful, otherwise general dialysis may occur. Anterior capsule can tear, or the posterior capsule there can be a rent posterior capsule as well. So the misdirection of fluid flow, or inadequate or excessive pressure of flow, too small a rhexis or a myopic patients, there all these complications may occur. So to conclude in the last, a good capsulorhexis is the most crucial step in phacoemulsification surgery. The surgeon must foresee any complication before it becomes severe. So we should learn to identify the complications when they are taking place, so that it is easier to manage them faster in early stage. And whenever such problem occurs, we anticipate some complication is taking place, maintain your cool to tackle any complication or any deviation from the normal if it occurs, and ensure the complete hydrodissection and delineation at the end of this stage. Thank you very much.
Thank you, Sanjeev. You nicely covered the two important areas, because for any cataract surgery, I think we have to open the window, and capsulorhexis has really changed the concept of doing phacoemulsification in today's time. Because I know that when we started doing phaco, we had no idea what was capsulorhexis in those days. Now, if I see backwards, laugh on myself how we did phaco in those days, doing an envelope technique or doing a can opener for a phaco, my God. But now we understand it is so important to have a good rhexis for even not only for phaco, even for SICS, people do such a beautiful rhexis in these cases. And hydrodissection, yes, it is so important. We'll come to that subsequently also. Let's finish the other steps, then we'll have a good discussion. Sucheta, you can invite Professor Tushar.
Yeah, next speaker is Professor Tushar. Yeah, Professor Tushar is currently now the professor in cornea and cataract and refractive surgery at RP Center, New Delhi. He is the youngest one to join at the age of 29 at AIMS RPC Center, AIMS New Delhi, and he has 100 peer-reviewed research papers, and he's having around 20 innovative surgical ideas, skills, and all those new things. And he's a recipient of a lot of awards, some being the Young Scientist Medal and Achievement Award in AO and APAO. He's a young dynamic surgeon with an innovative skill. hear from him the new techniques. So Dr. Tushar, to you to speak on very important thing, nuclear management, both in soft and as well as hard cataracts.
Is my screen visible now?
Yes, your screen
Yes,
is
sir.
visible. Just go full screen. Yeah.
Okay, okay. Thank you very much for inviting me to be here. And I'll be speaking about nuclear management, soft and hard cataracts. Now, if someone is here is familiar with the Pareto's principle, which says that 80% of the achievement is done by 20% of the people, and 80% of the problems are also caused by 20% of the people. In a similar manner, when we move to practice, we'll find that most of the cataracts are between grade 2 and 4, and 80% of, I would say, just to generalize, and they are the ones which get away easily. And it's the grade 1 and the grade 4 plus cataracts which cause most of the problems. So I'll be first talking about the soft cataract. So just to clarify for the audience's sake, this is the cataract which is not amenable to removal by just phaco aspiration. So with the IA probe, so it is just harder than something which would be taken out by a IA probe, but at the same time not amenable to the routine chopping techniques. So I'll start with the very ideal scenario where you do a hydrodissection followed by hydrodelineation. So in such cataracts, if you are able to achieve multiple planes of hydrodelineation as is visible here, so what you have done is that you have separated out the central small nucleus from the other layers of the lens, and this gives you a very small nucleus to handle, which can be removed in toto. And this from my perspective, this is the ideal scenario if I am handling a grade 1 cataract. But this generally doesn't happen, and this is one of the rare occasions when this happens. But if it does, then the surgery becomes very easy. As you can see that the central nucleus becomes mobile, and it can be just removed with the help of the phaco probe without needing any kind of chopping maneuvers. And the rest of the nucleus and the rest of the epinucleus and the cortex also comes in separate layers. And the case is done in no time. But let's see the scenario which is more commonly seen. You will see a mid-dilated pupil, because you'll find that the soft cataract, generally you are operating on diabetics where they have a mid-dilated pupil, and the golden rings which you saw in the previous case are generally not visible in such cases. And when you try to rotate the nucleus, it's not just the nucleus which is rotating in the bag, but you end up rotating almost the entire lens in the bag. So what would happen is that when you try to do phaco in such cases, you will find that the phaco probe just goes through and through, and you are not able to get any purchase on the nucleus, as you will see here. Because the moment you try to initiate some sort of phaco to impale your needle, the phaco doesn't go through. Now at this point, you can do two things. One is that in your settings, you can try to reduce the phaco power, and you'll people who are doing phaco here, the residents, they should understand that the phaco power can be set in a linear mode. So you can begin from, in normal phaco surgeons keep the settings from say 20% to about 40 to 60%. So thereby meaning that when you initiate phaco, it begins at a certain level, say 10 or 20%. But if you are encountering a very soft cataract, you can actually lower the settings to begin from 0% phaco, and then gradually, which goes up to say 30 or 40. in that case may allow you to have some purchase on the nucleus. But as you will see that even with that, there is no way that this I'm able to get a impalement of the phaco needle into the cortex, the nucleus. So in such cases, what I do is I try to debulk the central part. I have mentally have given up that, you know, I am not being able to chop this nucleus. So what I do is I resort to visco-assisted phaco in such cases. So what you do is you first decompress the chamber, make sure that the AC is little shallow and the eye is pretty soft. And then you advance your cannula, which has methyl cellulose in it, into the capsular bag in a motion as if you're trying to do hydrodelineation. And what you are doing right now is you are creating viscodelineation, which is delineating the central nucleus from the rest of the epinucleus and the cortex, and which results in the lifting up of the central nucleus outside the capsular bag. And at the same time, what you have done is now you have created some space with the viscoelastic in this area between the capsular area and the nucleus area. And it is in this space that you will put your probe and remove the nucleus. Again, this is done with the lowered torsional settings because you are not really requiring much of phaco energy in these areas. And you can repeat this a couple of times to remove all the pieces, doing viscodelineation, creating space, bringing out the nucleus towards the center with the help of methyl cellulose, and removing this. This is my go-to technique if I encounter a soft cataract in which I'm not able to do the first type of technique. Then I resort to this, and it works quite well for me, and I find that it's quite safe also. Okay, so this is another example of the same thing. So you'll find that I'm unable to get any purchase on the nucleus. So once I give it a couple of tries and I find that it's not amenable to chopping, then I just switch over to this technique. I will do a central debulking. As you can see, the torsion here is not much at all. Ideally, it should be lowered to 0 to start from 0 if you are having a soft cataract. But then you do just repeat the same thing. Inject methyl cellulose as if you are doing hydro delineation. Bring it towards the center. In these cases, it's helpful if you have injected viscoat in the anterior chamber too, because this is anterior than normal. So viscoat would help to protect the endothelium in such cases. But this is my go-to technique if I encounter a cataract which is not amenable to chopping. Coming to hard cataracts, technically speaking, I find that the soft cataracts are actually the hardest to do. And the hard cataracts, or the so-called grade 4+ cataracts, are actually slightly relatively easier because the technique is much more well-defined. And so coming, I'll just go step by step. What are the differences from the routine cataract surgery as compared to when you are handling a grade 4+ cataract? So the first is that your rhexis size needs to be little larger than normal. It cannot be small. So either if you're always doing an ideal size rhexis of 5 millimeters, then it's fine. But if there are people who prefer a little smaller rhexis, say 4.5 or 4.2, in those scenarios, I would recommend that the rhexis needs to be a little larger, because most of your phaco action is going to be in the mid-peripheral area rather than in the center. So aim for a slightly larger rhexis, and always stain these capsules, even if they are not white cataracts, because you're going to be very near the capsular edge. In these cases, the rhexis part has been slightly forwarded in this video just to save some time. So I'm trying to just trace out the pupil and do a rhexis as large as possible in this pupil. Now, again, in hydrodissection and hydrodelineation, in such cases, you will find that there is only hydrodissection. There is not much delineation because it's almost the entire cortical matter, epinucleus, and nucleus are all fused together, and it's essentially you are dealing with one large chunk of lens matter in the center. Now, the third difference, important difference, is in the nucleotomy in such cases. So in this case, you have to remember that the central nucleus is a very hard part of the nucleus, and it has to be treated separately with the rest of the nucleus. Now, there are two ways of doing this. In the last decade or so, the preferred technique was crater and chop, where you, using a low vacuum, you used to remove the central hard nucleus first and then attack the peripheral part. Now these days, since many years, I have shifted to a different technique whereby I just forget about the central part to begin with, and I go in the mid-peripheral part. And then using a sharp chopper, I chop the nucleus in the periphery, not attempting to go to the center at all. So I'm just trying to create peripheral cuts. So I'm not even bothering to go towards the center at this point. I'm just giving peripheral cuts. The idea behind this technique is that as you give peripheral cuts in the periphery, the central hard nucleus gets separated on its own from the rest of the nucleus, which is the one which actually impedes the complete chopping of the entire nucleus. And you'll find that after about 6 or 7 chops in the mid-peripheral area, you'll find that so I was not counting, but I think it's 7th or 8th chop at the moment. And you'll find that the central nucleus here gets separated, and this you can remove en masse. Again, you'd like to take a look at the settings here. So the settings here are my normal settings in a grade 2 to 3 or grade 2 to less than 4 cataract are 20% to 60%, which means that when I go into mode 3, my torsion will begin from 20% and reach up to a maximum of 60%. If I know preoperatively that I'm encountering a grade 4 plus cataract, then my settings, I keep the upper limit at about 90%. But I don't use longitudinal phaco at all in these cases. Only when there is occlusion and I find that there is a blockage in the piece, then I initiate longitudinal phaco. So this is the central hard part which has got separated. So you have to now imagine the anatomy here. So the central core of the nucleus has been removed. Now what you are left with is the peripheral part of the nucleus, the epinucleus and the cortex, which are fused also. So now you have already now pre-chopped those pieces. So now the chops will extend to the center and the pieces will also start to become free. You'll also find that the removal of the central nucleus has made a lot of space available in the bag, and there is much less lateral movement of the pieces. And now you can actually go to right to the center and remove these pieces. Other thing you have to note is the CD. So the CD is pretty high in these cases, and it in a true 4+ cataract, I found that it generally exceeds 25. Average is around between 30 to 35, and in almost black cataracts, it can even exceed 50. But the rule which I follow is that minimum to minimum, every 15 seconds of CD, I will inject viscoat, re-inject viscoat. But I tell my assistant or the sister who is assisting to give me a warning at around 12 CD, so that I don't have to sometimes stop in the middle of a chopping motion. But at a 15 seconds of CD, I will make a hard stop wherever I am, and I will re-inject viscoat. And that is really helpful in such cases because you're actually giving a lot of energy into the eye. And now that you have removed the central hard part, you will find that these peripheral petals come to the center quite easily, and you can remove them with phaco, and you repeat this process, and all the petals can be removed quite easily. Last thing in these cases is that the epinucleus itself is quite hard. So if you are used to removing this with an IA, I would recommend that at least in these cases, you should learn how to remove these epinucleus shells with the phaco probe itself, because they themselves might require some phaco energy. So remove the epinucleus with the phaco probe itself. Just be careful about the surge at the time behind. So you can just do it a little anteriorly for safety's sake. So remove this thing. I've just retained this part just to demonstrate that if you use Viscoat, you can see the CD has been quite high in this case, 38, but you can still find that there are no folds or anything or edema in the cornea, because if you use Viscoat every 12 to 15 seconds of CD, you'll find that there is the corneas are absolutely clear the next day, and the patients do quite well. So this is my standard technique in grade 4 cataracts. As I said previously, these are actually a little easier than the softer cataracts because there the variability angle is more. Here you are quite pretty sure about the actual physical happenings which are going to happen. Now, just to summarize, a thorough hydrodelineation which results in multiple golden rings is the ideal scenario while handling a grade 1 cataract. It facilitates the removal of the nucleus in toto. If you find that the cataract is not amenable to chopping, viscoelastic or methylcellulose assisted removal is a very safe option. While handling harder cataracts, you have to go for a slightly larger axis. Smaller axis will really impede your surgery, and a dispersive OVD injected at regular intervals aids in phacoemulsification. The central hard part of the nucleus should be treated separately from the rest of the nucleus. And as I said just previously, repeat OVD injections after every 15 to 12 to 15 seconds of CD. Thank you very much for your kind listening. And I'd like sir, because sir is the only person who have seen chopping grade 1 cataracts, and I've over so many years still I have not been able to pick up his technique of chopping grade 1 cataract. So if he can tell me secret today, I'll be very happy.
Thank you, Tushar. Wonderfully, described the various aspects of handling two difficult zones, soft and hard, together, and beautifully shown. But you are right. It all depends on how you handle it, and you described beautifully the phaco energy should be decreased so that you don't eat out the soft, peripheral part in these cases. But a trick is doing a good delineation, which you rightly showed. There are people who do a different techniques, and Dr. Tushar nicely said everybody has to develop their own techniques to handle cases. And the technique which can be replicated by most of us would remain in hands of most surgeons, and that is the best technique for any type of procedure. But to handle these cases, and you know that preserving endothelial cells function is one of the most important issue for all intraocular surgeries, and holds true for our cataract also. In fact, we all do a soft shell technique for all type of cases, not only for hard, we do for all cases. And that's that should be almost compulsory for anybody who is doing a cataract surgery nowadays. Think about endothelial protection in these cases. Thank you, Tushar. It was beautifully described.
Thank you, sir.
Should we go to the...
Yeah, next I call upon Professor TTL sir for his presentation.
Okay.
So Professor Jeevan S. TTL is the head of cornea, cataract and refractive surgery at the RP Center, AIIMS, New Delhi. He is the chairman of National Eye Bank. He is a Padma Shri awardee and achievement award for a lot of orations and in AOA, APAOA, and he has more than 250 publications, 30 orations. He has a lot of things. So best part about him is he's a surgeon, a teacher, and a very good human being, and who has helped us for this webinar. So over to you, sir, to talk on posterior polar cataract.
Thank you, Sucheta. First of all, getting everybody together is a big thing nowadays, and happily we all are together today, and that will definitely help for future ventures also. So I think we had a nice beginning on how to perform basic steps of cataract surgery, right from SICS to phaco. And some of the top surgeons have talked about difficult scenarios also, like femtosecond, corneal haze, and the newer IOLs. We all do challenging cases. Posterior polar cataract also has some of the challenges for us. And if you understand the type of various presentation of posterior polar cataracts, and then change your surgical aspects, will definitely make things easier, simpler for us. We all understand that there's a higher incidence of a posterior capsular dehiscence during various steps of a phaco surgery, right from the hydro procedure to a nucleotomy. But classically, we all understand the highest incidence of rupture of posterior capsule or dehiscence does happen after nucleotomy is completed. So that is how everything has to be understood very, very clearly. The classical description of surgery or a phaco in posterior polar cataract is do avoid hydrodissection. Hydrodelineation has to be done in such a manner which gives a cushion of cortical matter or epicortex in these cases, and do a slow motion layer by layer phaco in these cases. Just to show one small video on the posterior polar cataract, the standard technique which we see, this is a disc which is around 3 millimeter right in the center. I'll just fast forward the basic technique. The rexus has to be of a normal size. Classically, it should be around 5 millimeters. Many people talk about doing an oval rexus for a posterior polar cataracts also. That is desirable in those cases where you have a pre-existing defect. If you don't have, then routine capsular rexus should be done for these cases. So this is how we do one delineation. Strengthen the delineation first, then do a peripheral delineation of this. So I have two good delineation for this case because we are not going to do hydrodissection. No rotation is done in these cases. So this is just a delineation to show that. Then what Dr. Tushar is talking about, I'll do a central sculpting because these are mostly soft nucleus. So once you do a central delineation, the energy, you can say zero torsion and zero longitudinal this thing. No phaco should be used at this stage. That is a trick, Tushar, for these cases. Zero, only vacuum should be used for this. The central disc, as Dr. Tushar showed, we have taken our central disc, then scoop out the peripheral nucleus without rotation. So that is important here. So I have this nucleus remaining here. This epicortex will be now peeled off from periphery to center. And you can see that still the central area is clearly delineated. We have an intact posterior capsule here. And these cortex can be taken away. If you experience, you have good practice to your machine, you can do epicortex and cortical removal also. The remaining part, which is subcortical, sometimes difficult to remove with a phaco handpiece, that can be done by the hybrid technique, which Dr. Tushar had described beautifully. See how I remove my second instrument, then inject another instrument. At this time, my irrigation is continuous. So there's no decompression of anterior chamber, which is important to realize in all difficult scenarios, not only posterior capsular, posterior polar cataracts, for a subluxated cases also. Never let your chamber collapse, because more number of chamber fluctuation, more chances of posterior chamber complication also. PBD, cystoid macular edema will also get enhanced. The entire thing has been taken away. I'll remove my second instrument. I'll continue my irrigation there, then inject viscoelastic to maintain the pressure. So that is very important for a posterior polar cataract. You can still see a little bit of a tax here. Then inject IOL in these cases. So this is the surgical technique which is desired. But there are many people who think of doing hydrodissection in posterior polar cataract. We understand hydrodissection makes surgery very, very simple for all of us, faster and more simpler. So how do we decide no hydrodissection or hydrodissection in posterior polar cataract? So this is only based on a pre-op assessment, slit lamp, anti-segmental OCT, fellow eye examination, or intraoperatively by using IOCT in these cases. So this is a classical picture of a posterior polar and slit lamp. The size of disc is discontinuity. Posterior to the disc is important to see. And hardness of nucleus is also very important to realize. Harder the nucleus, more chances of a defect being there in these cases. So this is a case which has a pre-existing defect. You can see all those granules. So slit lamp will also give you a very nice assessment. Anti-segment OCT and integrated microscope OCTs will give you, and Dr. Mahipal talked about, femtosecond also has OCT attachment that can give you a picture. So if you have an anti-segment OCT, you can see this disc size and clarity of posterior capsule in these cases. And you can see this is a totally open posterior capsule in these cases. So this is our publication on intra-op OCT, because anti-segment OCT can give you a morphology. But what happens during the procedure can only be seen with the IOCT. So we described 3 types of posterior polar cataracts, excluding the open posterior capsule in these cases. So these are basically, this is a type 1. You can see the disc here. If you see the OCT picture here, you have a clear demarcation of a posterior capsule. There's a clear homogeneous space between the opacity and the posterior capsule. So these look like a posterior polar, but they may be like a posterior subcapsular type of cataract. In these cases, you have a safety in these cases. This is another type 2 type of cataract where peripheral area is clearly delineated with posterior capsule, but central area you can't see. So this is a doubtful case. This is a type 3 where you have a larger disc, which is more than 4 millimeter, and the entire range of posterior capsule is not visible. So these are high risk cases. So let's see, this is a type 1 case you saw earlier in my video also. You can do a rhexis. So I can just see the entire, I can delineate my posterior capsule and posterior plaque, and accordingly I'll do delineation. So I've done a hydrodissection, hydrodelineation here. You can see a nucleus and the entire epicortex is visible here. As I said, this is a type 1, so we'll be doing a hydrodissection also in this particular case. So you'll see hydrodissection wave, you can saw here, and subsequently space here. So this is hydrodelineation, this is hydrodissection here. And see, the surgery will be completed subsequently without any difficulty. So surgery becomes very, very fast if I've done a hydrodissection in these cases. I've done a complete nucleotomy, still you have a cushion intact and posterior capsule intact. So that's the advantage of having an IOCT in your hand. It's a type 2 posterior polar cataract. The central area could not be delineated. In these cases, you have to avoid hydrodissection. You can see this is hydrodelineation being done. You can see the space being built here. As soon as you inject the fluid, see the space here. So amount of fluid injected should be also minimal. Otherwise, you'll have a large distension and immediately you'll have a posterior capsular adhesions. How beautifully you saw the hydrodelineation being done in this case. So in this particular case, I had an in-orbitant hydrodissection also, you can see here. But luckily, despite being a type 2 cataract, we didn't have adhesions in these cases. So I could realize there's a hydrodissection happen in this patient. Accordingly, my surgery planning changed, my parameters changed. I made a bottle pressure IOP of around 30 in this case. So the surgery becomes slow. And you can see effectively I've done the entire surgery. Because hydrodissection was there, entire epicortex moves very fast, and cortical removal also becomes very easy once you do a good hydrodissection. You can see intact posterior capsule in IOCT here. This is type 3 where nothing is visible beyond. You must avoid hydrodissection in these cases. Do delineation. Normally these cases would have a slightly harder nucleus also. All type 3, type 4 will have a harder nucleus. And the nucleotomy has to be done as described by Dr. Tushar. You can see a multiple planes of hydrodelineation is being done. Subsequently, completion of nucleotomy, the entire thick epicortical cushion is there. We'll peel off from center to periphery to center, remove the central part together towards the end. So whatever addition you have, it will get automatically delineated. There will be an internal hydrodelineation once you peel off from periphery to center, and the entire disc comes off. So this is our incidence of cases. Type 1, type 2 are very common. You can see 30% type 2 and 47 is type 1. Type 3 is less. Type 4 is much rarer. And incidence of PCR is slightly higher on type 2 and type 3. You can see 1 out of 12 and 2 out of 9. And femtosecond laser, this is my technique, which is followed by many, many people, where we do a femtosecond multiple rings and multiple chops. So that makes a safety cushion, 3 rings and multiple blocks are there. And each block is taken, primary block, secondary, tertiary blocks are taken one by one. You can see here. and towards the end we remove the epicortex. So that's a replication of a manual technique in a femtosecond and gives a very good results. So I would understand hydro procedure should be done, but how we decide on based on a morphology only. And once you have clarity of posterior capsule like type 1, hydro dissection along with hydro delineation is done. But if you have no clarity of posterior part, then don't do hydro dissection, just do delineation and go as it is. So if you have IOCT, it gives you a real dynamics on the table, you know what has happened. And it can also pick up the high risk factors, high risk morphology of posterior polar cataracts. But yes, if you have a posterior capsular defect happening, like in this patient, I was doing a good nucleotomy, then subsequently towards the, I was doing aspiration of a cortex here. You can say cortex being aspirated because we don't do hydrodissection. Entire epicortex is attached to the posterior capsule. And that is a time where you can have a defect coming. You can see a clear linear defect has come up here. But this is the stage where you have to safeguard the posterior capsular opening by injecting dispersive viscoelastic. So if you have Biscode, that's very good. If you don't have that, you can use methyl cellulose also. That can also retain the in the anterior chamber and block the opening here. So this is what you can see here. I'll remove my second instrument at this stage because it will be difficult to remove this particular chunk here. So remove this instrument first, then use dispersive viscoelastic to tamponade, which is going to decrease the bulge of vitreous coming to us anterior chamber. So this is very important. Use dispersive viscoelastic. Don't take away the IA handpiece in these cases. You can see it will plaque because this opening is quite small. So we can do a primary posterior capsular axis. You can see this is the opening here. Then I'll do a good primary capsular axis with ILM peeling fossils and then complete, and you can implant your IOL subsequently in these cases. Once you have a vitreous, then vitrectomy is required, and staining by triamcinolone is very good thing. Even in a case where you don't feel vitreous is there, you must stain and see what is the ultimate status. I'm using a foldable lens in the bag in this case, but always judge your scenario. If your PC tear is much bigger, go for a multi-piece lens in the sulcus, get optic capture done in these cases. To summarize, what are the key points which I highlighted here? So there are 7 points here. One is a good pre-op assessment for these cases. See the morphology, what type of posterior polar cataracts you are seeing. So this can be seen as slit lamp. This can also be seen by anterior-segment OCT. So I would suggest all of you should do anterior-segment OCT and delineate what type of polar cataract you have. Then do a surgery planning accordingly. Second is adequate hydro procedure. So that depends on a type of posterior polar cataract. You can see I'm doing a hydro delineation here. You can see a beautiful hydro delineation here and see the thickness of epicortex, which is around 1,000 to 1,000 microns in what we do in a laser surgery. But here also you can see that. Avoid hydro dissection in type 3 and type 4 cataract, where you can't delineate the posterior capsule with your anterior-segment OCT or IOCT if you have in your operation theater. Then do a layer by layer phaco with a moderate parameter, block by block nucleus disassembly in these cases. Always identify for a complication. Most important complication is posterior capsular tear adhesions. If you pick up early, you can safeguard the complication getting worse in your case. That is right from the hydro delineation and hydro procedure. If you have a pupillary synapse sign, you be careful, you can have a nuclear drop in these cases. Other important thing is, thorough pre-op counseling, because your surgery can change, your IOL can change. The patient should be warned, you may have to change the IOL, you may not be able to put IOL. All those things has to be highlighted to your patient. If you remember these points, it will be simple for all of you. Thank you for your kind listening.
Thank you, sir. That was really wonderful. I now request Rajesh Sinha, sir, to speak or discuss some few points before we take up the next speaker.
Sir has highlighted most of the points, so there's hardly anything left to speak. Very good points sir has told that we have to be very careful in doing hydro procedure, and many times what happens that there's a tendency to do hydrodissection first and then do hydrodelineation. So we have to remember that if there is a morphology of posterior polar cataract, and in that case, we should avoid doing hydrodissection. There may not be a defect, but many times you don't have IOCT and you don't have the facility. So you may not be able to judge what sir was showing. So in those cases, it's better to take precaution. The only problem in such a scenario is that while doing cortical aspiration, the cortex will be quite stuck up in the capsule. You will require an extra minute to do the cortical aspiration. Otherwise, it's always better to play safe. And most importantly, the central ring that is there in posterior polar cataract should be removed in the end, because if there is a very thin capsule in that area, even if there is no adhesion, sometimes because of the because of the pull, because that area is weak, it opens up. So that part should be removed in the end, so that you have removed the cortex and everything from the sides, so you're not left with much. And once you see, even if there's a defect, one point again, which should be, I just want to highlight that point which sir has already told, that if you see a defect, then you should immediately, from the second instrument, remove the second instrument from the second port, you inject dispersive viscoelastic, and so that the defect doesn't enlarge. So I think these are some of the things that we should be careful about.
I think I learned one thing that
can I ask one question?
Sure.
Dr. Sar has shown in soft cataract visco dissection. Is there any role of visco dissection in posterior polar cataract, especially in peripheral cortex, when it is very sticky to remove by?
Yes, people have described this, Amit, and people do also, because as we talked about, Dr. Rajesh also highlighted, when you have an epicortex left, first peel off little bit from the periphery, don't come to the center, leave it there only. So this will allow some fluid to seep in. If that doesn't happen, you still have a stackiness, you can inject a dispersive viscoelastic. Don't inject cohesive. Cohesive will never seep through. You inject dispersive, it might seep through the entire thing, entire epicortex will come up, then easily you can take out. Even you feel, it's a normal. If you are hesitant to aspirate, always put a viscoelastic bolus behind, so that your aspiration becomes simpler and you can do a safe job in these cases. So that should be practiced in our routine cases also, not only posterior polar. Okay, Sucheta?
Learn is we should also use routinely the anterior segment OCT. Actually, that gives us a lot of idea. So
it is a must
in all
instrument
our cases,
nowadays.
Yes.
Okay.
So we have speaker Professor Rajesh Sinha, who is the professor in cornea, cataract, and refractive surgery at RT Center near AIIMS, New Delhi. He has 334 total publications, lot of textbooks, educational manuals, done a lot of multicentric trials. He has received various awards, some of them being the Achievement AO Award, the IARS Gold Medal, Econ Gold Medal, and he's the treasurer of AIS and iBank Association of India, and the general secretary of ISC-KRS, which has supported this program. So over to you, sir, for your presentation on cataract in small pupil, hooks and rings.
Thank you, Dr. Sucheta. It's a wonderful initiative that you have taken, and I'm really thankful to you to have included me in this webinar. I'll be talking about phacoemulsification in small pupil, and whatever I'll be showing, I don't have any financial interest in that. The best thing a cataract surgeon feels is when he sees a pupil like this, a well-dilated pupil, when you can do all the manipulations without any problem. However, the pupil may not be large, may not be dilated all the time, and it may be small. So the question is that what is a small pupil? So any pupil of inadequate size that the surgeon believes he might struggle with when performing the procedure. And any pupil of inadequate size in which you cannot see the movement of the tip of your instrument should be considered as a small pupil. Now, you can manage, an expert surgeon can manage in a pupil of 4 or 5 millimeter size. And there are certain tricks that you use, high viscosity viscoelastic. Then you do a nice hydro procedure. You don't move your main phaco probe. You just, with the help of a second instrument, you keep moving and bringing the nucleus pieces in the center, and you can emulsify. That is the trick, to emulsify the nucleus. And then while doing the cortical aspiration, you should definitely see the port superiorly. So it should be under direct visualization, and then only you should take it underneath the iris and the cortical and the capsular margin. So this way, an expert surgeon can manage cataract surgery without use of any gadget. But we cannot advocate that, and we cannot teach that. So the idea is to do all the procedures under direct visualization, and for that, pupillary enlargement is essential. It can be done pharmacologically by certain drugs, or it can be done surgically by use of certain rings, hooks, or you can do syneculisis, you can do iris stretching, etc. Now, this is a case wherein the pupil is about 4 to 5 millimeter size. So you can use intracameral adrenaline to dilate the pupil, and also use high viscosity viscoelastic. Apart from adrenaline, these days we have the drug, one drug, phenocaine, also available. Omidria is available internationally, which contains ketorolac and phenylephrine. So these can be used intracamerally to enlarge the pupil. And once it enlarges to 6 to 7 millimeter, you can use high viscosity viscoelastic to enlarge it further. And this much of size of pupil is something which we all desire. And if that is there, then we are very happy. But if it's not the case, then in that case, people have used iris retractors, and we all use it. Now, one thing I would like to highlight here is that when you're using iris retractor, there's a general tendency to use 4 retractors and to make the main port in between the 2 retractors. Now, what happens that with these 2 retractors, the iris gets taut. This is the pupillary margin that gets taut and gets a little up. It's a little raised. So whenever you introduce your phaco probe inside, there is risk of iris chafing and causing damage here. So what we advocate is that we should use 5 hooks. 2 of the hooks can be used just adjacent to the main incision. So whenever you can see the iris tissue is retracted till the edge. So whenever you are introducing the probe, you don't damage the iris tissue there. So as you can see here, the iris tissue is right up to the edge here. So whenever you are introducing anything, you're not touching the iris tissue. There's no iris chafing, there's no pigment dispersion, there's no iris atrophy in the post-op period. So this is what I would like to emphasize when you're using an iris hooks, which is the most commonly used pupil enlargement gadget worldwide. Now, this is another tool which can be used. This is a Grather pupil expander. It is a soft silicone expander which has a groove in the. It's a kind of a tire kind of a thing, wherein there's a groove and the iris tissue is engaged into this groove like this, and it is quite soft. And you can have a nice about 7 millimeter pupil, 6.5 to 7 millimeter pupil. And you can perform the procedure nicely. And this is so soft that once you have used it and you take it out, there is no damage to the pupillary sphincter. The only downside is that it cannot be reused. So this is the surgery done, and then IOL is implanted, the viscoelastic being removed from behind the IOL. And then you can remove this, you can just pull it out, you can disengage from the pupillary margin, and then you just pull it out. It's very soft, it comes out easily. And it is so soft that it doesn't cause any damage to the pupillary sphincter. That is the advantage. Then the most common ring that is used worldwide is Malugin ring. This is the Malugin ring, which has these four scrolls, and this is pulled into its plunger, and then this is introduced into the eye, and then the distal scroll is engaged into the uveal tissue, into the iris, and then the two scrolls also come out side by side, and then you engage these scrolls into the pupillary margin, and you get a nice 6 to 7 millimeter pupillary size with this. And you can go ahead and complete the procedure, and once you have done it, implanted the intraocular lens, you can disengage the scroll, the proximal scroll, and then you can pull it. Now, while pulling, one thing you should be careful is that these two scrolls, they have a tendency to get stuck here. So you have to use a second instrument to gently tap when these scrolls come just at the edge of this plunger, and then you can take it out. Although the manufacturers don't advocate reuse, but it can be sterilized by ETO, and many of us, including myself, I've reused it 4 or 5 times in with one ring. Now, this is a Oasis pupil expander. You can see that this is also a good expander, but the downside is that it has these bulky foot plates, bulky plates here. So when you introduce into the eye, this is the Oasis pupil expander. And this is again pulled in the same manner as you do the Malugin ring. And when you introduce it, what happens that whenever you are moving your probe or any probe inside, it keeps touching the foot plate, and it moves the whole of iris tissue. So there's a risk of release of inflammatory mediators because of the movement of the iris tissue with that. So, and it is a bit uncomfortable. So given a choice, I will not use an Oasis pupil expander. And same is for eye ring also, Visitec eye ring, that is also a bit bulky. I mean, these are good gadgets, but then a preferable one will be a Malugin ring or an iris hook, or something like this, which is a Bhattacharjee ring, which Suvain Bhattacharjee has introduced. It can be introduced into the eye even through a 1 millimeter incision through the side port. So it is a good one. It has 6 notches actually, you can see here, and it creates a hexagonal pupil. So you just engage in the iris tissue into the notch, and you get a hexagonal pupil. That's why it's called BHEX. And then you can go ahead and complete the procedure. And once you have completed the emulsification and cortical aspiration, you can just disengage these notches, and you can take it out very easily through the whichever port you want, to the main port, or you can take out from the side port as well. So that is the advantage with this Bhattacharjee ring. The only a little downside is that it is not as firm. So sometimes the pupil is too rigid, a little bit too rigid. Then in that case, it may not be that effective as a Malugin ring or as an iris hook, which is used more often. So the basic idea of using all these gadgets is to emphasize that when you are doing a procedure, you should be able to do it under direct visualization. That is the basic idea. One can manage even with a small pupil with expertise, but you cannot advocate and you cannot show it to your juniors. You cannot teach to your juniors. So the basic idea to minimize damage to ocular tissues is to see what you're doing. And that is why you require these useful gadgets. So thank you very much for your patient listening. And if there's any question, I'll be very happy to answer.
No, Rajesh, it was wonderful. Videos. You have good collections and beautifully shown the devices. And I know that sometimes small pupil can be very, very challenging to us. And have you encountered some cases where you can have bleeding when you put these rings, especially post-uveitic patients, and next day the inflammation is much more?
Absolutely, sir. Whenever we use these gadgets, you are handling the iris tissue. The risk of inflammation in the post-op period is high. So that you have to be prepared with. Particularly in post-uveitis, you can have some, neovascularization also. You can have NVI also. And in that case, whenever you are using these hooks, you can damage these small twigs, and there can be, blood in the anterior chamber. So that is very much there. But if it's there, you just wash it off. Use this Viscode, the viscodispersive viscoelastic, as well as high viscosity sodium hyaluronate. So all these things do help in stopping the bleeding. But yes, it can happen.
Rajesh, most of us will be using, iris hooks because other devices are quite expensive for us.
Yes. Yes.
And there are, I think, some indications where, these rings or devices cannot be used.
Yes.
And I think hooks are very, very handy in most situations.
Yeah.
Can you do a surgery, small people, without using devices? Some types of people?
Sir, I think most of us who can manage cataract surgery even with a small pupil, we can do it. And that's what I was showing in the first video. In some scenario, as you said that, these rings may not be desirable in certain conditions and situations. And that is, one is post-uveitis. So post-uveitis, it is always better to use the iris hooks and whenever there is a pupil is very stiff, in that case, the hooks that helps. The rings are not that very effective. Even for IFIS, I think the iris hook, I will prefer iris hook over any other ring. So that is what.
Especially if you have meiosis happening, after you have done nicknotomy in between, where the rexis orientation may not be visible to you. In those cases, hooks are very, very handy.
Yeah.
And I've seen some cases where you're putting a toric IOLs and pupil constricts. There again, one or two hooks will give you that access to your placement of IOL is very handy. Absolutely. And they are quite cheap, and they also can be used multiple times.
Yeah.
Thank you, Rajesh, highlighting all the.
Just one thing I would like to add here, sir, that once we have done the rexes and in between, if we are using the hooks, we have to be very careful that we don't catch the capsular rexis margin. So we should definitely inject high viscosity viscoelastic underneath the iris.
Correct.
So that the iris lifts up and then you can hold it.
Okay, let's go to the next speaker now. It's our pleasure to invite the main person today, Dr. Sucheta. Do we have her slide also? Admin? Okay, doesn't matter. And she's a young faculty heading the department in Bhubaneswar AIMS. And I had a pleasure to be there, I think once or twice. She has organized.
Arvind is putting up the slides, no?
Okay.
Arvind? Can you?
Yes, sir. Yes, sir. Yes, sir. Yes,
yeah, please.
Okay, there it is. So we have lovely Sucheta there, additional professor heading the department. And I think it's a responsibility to all AIMS head of departments here to create atmosphere where we can have a nice interaction amongst each other. Whenever I have an opportunity, I talk on this, but to implement things are difficult. But once we are together in future, we can do it. There are many areas, right from the patient care to research, we can be together. She has a special affinity to pediatric ophthalmology, and she does a lot of squint and pediatric cataracts. And I know that she is very fond of pediatric cases. More than 45 publications and multi-centric clinical trials too. And she's done a lot of presentation in international national forums. And I know in Odisha, things are very difficult, and she's working on a pediatric that is all the more challenging. And I wish all the success for her. I know I've been to Odisha, Rajesh also, peripheral places. I've been to Sundargarh, which is one of the remotest tribal area. But things will come up. Let's hear Sucheta. She's going to talk on a pediatric traumatic cataracts.
Sir, can you see my slides?
Not yet.
Yes, we can. Yes, we can see you.
No,
We
no.
can see you, but no slides.
Slides.
Share your slides.
Share slides.
Yeah, now you can see the slides.
Yes, definitely.
So very good evening, and I'll be talking on pediatric traumatic cataract. I have no financial interest in this presentation. Well, traumatic cataract accounts for 12 to 29% of all pediatric cataracts, and it is the most common cause of visual blindness. And the patient can present to you at any age with different morphology and different situations. So very important thing is to look for what is this ocular trauma, whether it's a blunt trauma with a cataract or it is a penetrating injury. If it is a blunt trauma, always look for iridodialysis, hyphema, or what is happening to the posterior segment, whether you have a vitreous hemorrhage or a retinal detachment along with the cataract. If it's a penetrating injury, invariably there will be a corneal laceration, there will be loss of the capsular integrity, and iris trauma will always be there. So different scenarios they will present to you, and when, how, and how you will go about it are all the more issues and debates which goes on. So there are a lot of dilemmas, concerns, and considerations, and I'll be talking on this 5 important things. So the major question which comes, should we at the time of primary repair, should we take up the repair only or the cataract management? What is the ideal timing for cataract surgery? What about the IOL implantation? Do we do it as a primary or as a secondary procedure? What about the additional surgery which will be associated along with it? And very important are the medical legal issues and proper parent counseling. So let's talk about the first thing, cataract management during primary repair. So what do? If we say no, if you see there is a corneoscleral tear with not of much of a cataract and the child is 7 years old and there is a exudative membrane, so it's better just do a corneal repair in these cases and you can tackle the cataract afterwards after the inflammation has subsided. But if you see there is a corneal tear and then you see there is a breach in the anterior capsule and you see a lot of floppy matter which is coming out into the anterior capsule and the child is a 3-year-old, very important for us is we have to tackle both at the same situation because we have to have a clear visual axis because amblyopia is an important cause. So the timing for cataract surgery, if you have managed the corneal repair. So how early do we take it? So early intervention should be next day, within weeks, few months. These are the questions which is invariably asked. So factors for deciding decision making lies on the age of the patient, inflammation of the eye, and what is the intraocular spikes which you are getting. And if there is an intraocular foreign body, you have to take it immediately. So these are certain things which we have to consider, and usually there is no ideal time, but pediatric ophthalmology, if you take them, they say it's better we take around 4 weeks. But there was a study by Mihul et al. Who had said that you can, the period is around 5 days to 30 days. That is the thing. You can decide your cataract surgery after a corneal repair. Now coming to the most important question, which is always debatable, is should the IOL implantation be as a primary or as a secondary procedure? So in these cases, your best decision lies on the individual cases, how the cases are presenting to you. Now this is the child who came to us and there has been already a corneal tear which is repaired and the patient is presenting 2 to 3 months. You can see the loose sutures also in these cases. So we, the patient, we went ahead and child was not very cooperative. So we went ahead and did the surgery and removed the sutures there and there. Very important is if the child is less than 6 years, you have to do a PPC in these cases and going for a limbal or a pars planar anterior vitrectomy. So best avoided if it's an infection or an inflammation will be more in these cases, and if there is a biometry issues in this at that point. So what about the IOL par calculations? So which type of a biometry we are going to take in this case? So very important, when you see that the cornea is clear, you can go ahead and do a manual keratometry as we do in all cases. But if you see there is some, the mass are not very clearly seen, then you can take the help if it is an elderly child for the topo-guided SIMK. But if it's very, very distorted Myers, then it's better you go ahead and do a standard K in those cases. Now, if we are taking up an intraocular lens, then where do we place it? So in the bag is the ideal situation. If you have a good, you can make a good rhexis. Actually, pediatric cataract, or 50 or I can say 70% of your thing is over. In the bag, you can go in with a single piece hydrophobic acrylic IOL. But still, if you have a compromise on the capsule or anterior capsular breach, then you can go ahead and put a 3-piece or a PMM lens in the sulcus. But if you don't have any capsular support, you can go ahead and do a scleral fixated or a glued IOL as a secondary procedure. So there was a study by put a intraocular lens. But what we see after that, there is a very big posterior capsular plaque. So you take the help of your a lot of atrata or the microforceps scissors, and you try to peel it off from the posterior capsule. But if you're not getting it, then you can put an intraocular lens which will act as a scaffold, and then you can place it in the bag, and then take the help of the micro scissors and remove the plaque afterwards, making the central clear. Now, if it's a 7 years, 8 years child, then you don't have to go in for a PPC. But always remember, it's always better that we give a suture at the end to the, even though it is a clear cornea, we went ahead and gave a suture in these cases, which is usually advocated in a lot of pediatric cases. So your technique, this is another technique which is recently published in the JCRS. This team initially is talking about that initially, if you see an anterior capsular breach, we used to do a rhexis in this part, taking the part of that breach. But they are saying this will act like a band, and this is the banded technique they are talking about. So you make a small rhexis by pull and push technique, where you do a circular small rhexis in the remaining part of the anterior capsule. So even if you have a PC dehiscent posterior capsular rupture, you can put it in the bag. And what this technique does, that post-operative, we have a lot of optic capture. So pupillary capture will not occur, and you can have no amount of IOL decentration in these cases, or tilt, which usually leads to a lot of refractive errors and poor visual outcome. So this is a new banded technique they're talking about. And well, the long-term challenges are always there in cases of any pediatric cataracts, and naturally traumatic cataract will be more. And in these cases, it is a continuous process. You have to look for what is the post-operative inflammation, what is the pupillary optic capture. Then secondary cataract is quite common in these cases, and you should never forget to treat them with a very, very follow-up will be regular, and do a refractive correction, take care of the amblyopia management in these cases. There was a study by Verma et al. Who recorded that the incidence of PCO was quite less in the children, those who underwent PPC, than compared to those who didn't undergo PPC. Even they are above the age of 6 to 7 years. So they advocated it is better if you can go ahead and do a PPC also up to 8, it gives a good result. So what you should not forget is the parental counseling. You have to take the parents into confidence, because they are the main motivators who will bring the child for a visual rehabilitation. So my take-home message is plan for primary repair, and best to avoid cataract in the early stages, except when there is the anterior capsular tear. The timing of cataract surgery after corneal repair is around 2 to 4 weeks, but depending on the age and other factors also. IOL implantation results in the best visual outcome in all age groups. Long-term complications such as pupillary capture, IOL tilt, glaucoma, or retinal detachment have to be taken care of, and the patient should be followed up for a long time to have a good visual outcome. Thank you for this. And difficult situations breed astonishing result, and this is what we are all together, and we could have a webinar even in this COVID period with all of us together and learning much about it.
Thank you, Sucheta, for a nice description. Professor Kavita, like to comment on the pediatric cataract surgery?
Sir, actually, I really don't do much of pediatric cases.
Okay, let's have the expert, Dr. Tushar, who does a lot of pediatric cataracts. Because there are 2 or 3 important issues which has been highlighted.
Yeah, we had done a similar study completed last year that we had compared primary versus secondary IOL implantation, because the traditional teaching has been to avoid simultaneous cataract surgery when you are repairing perforations. There are a couple of absolute indications where you have to do cataract surgery, like as Dr. Parija said, that there is an anterior capsular rupture with free-floating lens matter in the anterior chamber, or an intumescent lens, highly intumescent lens along with the perforation. Then those are absolute indications of cataract surgery. That is out of the way. But then the question was whether you should implant an IOL primarily, or you should do a secondary IOL implantation with corneal perforation repair and cataract surgery. So we did the traditional teaching has been to leave the patients aphakic and then do a secondary IOL implantation. But in our study, we found that we randomized them to 2 groups. Either one group received the IOL along with in the primary setting, and the second group received IOL in the secondary setting. To our surprise, we found that both groups fared similarly. And as regard the biometry was taken from the other eye in all patients. So all bilateral. I mean, so there was no non-eye patient in the study. So so the biometry was taken from the other eye, and so the primary IOL implantation with a corneal perforation repair also fares well, and can be considered as a good option, and it removes the need for one more surgery. And sometimes, in fact, you find that in the secondary procedure, the iris has stuck badly to the capsule, and also all those problems can also be avoided. But you need to have a good inventory of IOLs for such cases, because you might need most of these cases, in fact, end up needing a 3-piece IOL. We planned for single-piece IOL in all cases, but we found that most of the cases got a 3-piece IOL, because the anterior capsule is ruptured. You're not able to form a good rhexis. Yeah, there is even a posterior capsular dehiscence in few cases. So 3-piece lens, and in these cases, I prefer to do a posterior optic capture with a 3-piece lens. That serves very well. That keeps the lens in place. There is no problem of iris capture of the lens. So it's a viable option in such cases.
Yeah, thank you, Tushar. Dr. Rajesh, Sucheta mentioned, there's one paper from Shankar Netala SN where they propagate, iris fixated, retrofixated IOs in pediatric cases. So what's your take on that?
Well, some people do it when the child doesn't have a capsular support, but I would personally never do it, because I have myself explanted a few of these iris clipped lenses, because what happens that disinclination is something which can be noted. Even those very size lenses, the ones that had a support of the lens behind, they had reports of disinclination. So these cases wherein you don't have any support behind, the risk of disinclination is high, and these children have a very long life to live, and iris atrophy, etc., can be noted. So I had a discussion in one of the ESRS also when somebody from Shankar Netala was presenting about this. So I told that my reservations about it, and he said that yes, that is true, but we have done it. So I personally would not like to do it. Anybody who is more than 4 years of age, I would prefer to do a intrascleral haptic fixation of IOL if there is no capsular support.
Okay, I think even that is a little controversial topic in pediatric patients. We don't know the exact cutoff for age group for a transcleral fixation also, but that will be a better option than putting into the iris in the pediatric patient. Like people like me, a conservative approach, I might just put them on a contact lens for some time, see what is the growth of eye in these cases, because implantation of IOL in a post-traumatic cases can have many other problems in the long run, as you rightly said, amblyopia treatment. But we have seen patients having a progressive myopia subsequently also in many cases. So all the way to assess these patients, see what is the eye growing in a different manner, then plan accordingly in these cases. So requires a lot of attention in these cases, lifelong. I think let's go to the next.
So one thing
I also had a
age
question.
of the patient, like the age, if it is 2 years old, these are the children, it is better to leave them FA kick and give contact lens than giving a lens in the first go.
Absolutely.
That is right. Yes, Sanjeev?
Something like the same thing, like what is the age actually you should prefer to implant a lens?
Okay. Yeah, Tushar?
Sir, above basically above 2 years, there is no controversy, I think.
Yes.
Above 2 years,
Before
above 2 years, bilateral. I mean, you're talking about traumatic cataracts or pediatric cataracts?
I'm talking pediatric cataract.
Yeah,
before 2 years of age.
So above 2 years, no controversy. I mean, even in literature, and if you see practice patterns, everyone is putting even bilateral. Below 2 years, slight controversy in terms of bilateral. So again, if you talk about unilateral, then everyone, even who are not very fond of IOLs in children, unilateral, no one will say that you leave the child FA kick. And the bilateral group extends the same logic that, okay, if you are willing to implant a lens in a unilateral eye at 1 month, why not implant it in both eyes? So as I heard, I remember Dr. Vasavada speaking a long time back on this, and I think I remember, I'll quote him on this, that below 2 years, it becomes a matter of the surgeon's comfort level with the IOL placement. So you will find surgeons that some are comfortable at 1 year bilateral implantation, some are comfortable at 6 months, some are comfortable at all ages. So you have to again come back and see your results, your comfort level. You have to have a little bit of, if you are just starting out cataract surgery in children, I would not recommend bilateral implantation in less than 2 years at all. Once you have built up a certain follow-up of a few years at least, you have seen how your children behave in terms of the anterior segment, in terms of the glaucoma. And secondly, the IOL power, because everyone will have their own sort of a modification of the nomogram of putting lenses in say less than 4 years, more specifically in less than 2 years, because there is a lot of undercorrection which is required. So again, coming back to bilateral implantation, as you go below 2 years, the comfort level will decrease. For example, for me, my comfort zone drops drastically below 1 year of age. Above 1 year, I'm pretty okay with bilateral implantation, but below 1 year, and again, I'll qualify the response that you have to look at other things also. Like, for example, if there is even a slight bit of corneal problem, say a microcornea or a corneal size is little smaller, or I have a slightest of the doubt of glaucoma, or there is some other anterior segment problem which I can visualize preoperatively, my IOL threshold will go again, age threshold will again go up. So when I talk about a bilateral implantation in a 1-year-old, I am talking about a very normal sized eye, normal sized cornea, very well dilating pupil is a very good sort of an indicator that the eye is normal. If there is any problem which is hiding, like a rubella cataract or any other thing, you'll find that the pupil doesn't dilate. That is a very good clue which I take. If the pupil dilates very well in a normal sized cornea, normal sized eye, my threshold to put the IOL is lower.
Okay. I think point well stressed. I think what about looking into the axial length of these cases? As you talked about microcornea, other things, axial length can also be an important parameter.
Yeah. So for example, less than 18 is an absolute no for me. Less than 18 axial length, I would not put a lens at all. And so you have to see a cutoff like that. And in any case, the power goes up so much below 18 that there is no point of putting a lens. Your residual refractive error with the maximum power available is 30 diopters. And even with that, you will end up, there is no point creating a refractive error of plus 10, plus 15 diopters with the lens. I don't see any logic in that. So you have to leave in fact, I'm not a very big fan of a very large undercorrection, because I'll rather take a 5 diopter myopia at 5 years or 6 years of age than have to make the child live with a +8 or +10 diopter error for initial 4 years.
Yeah.
That's almost as bad as creating an aphakia in the first place. If the child can wear +10 or +12, the child can also wear +20. So if you get my point,
point well taken. Okay.
Sir, I want to share one of the case of pediatric case I have done. In a child was around 9 months of age. I have done bilateral surgery. There, in spite of adequate vitrectomy, there was a repeated visual axis opacification. Probably as a parent was illiterate, probably they are not putting a SWAT. Is that the reason, or there is some other reason of visual axis opacification repeatedly?
Sometimes if the child has an associated condition
No,
like
pediatric
JRA or
as such will
something,
have lot of PCO. That is the thing.
if they have
So
something like a
repeatedly,
JRA,
2-3 times repeated surgeries are being taken in these cases.
Okay.
And a good PPC, and you have done a vitrectomy. So I think clear access, if it is done, you won't have so much of PCO. But then you have to take care of other things, whether the child is having other type of infection is there or not, and what was the cataract, if it's a very membranous cataract, or other things are associated, any syndromes are associated, or all.
Preoperatively, mostly screen, torch, complex, everything was screened, but no abnormality was there. But there was repeated visual axis opacification even after adequate vitrectomy.
In my whatever limited experience I have, whatever I've seen is that if in spite of the vitrectomy, if the PCO comes up in the first couple of months, I mean, considering you have ruled out other things like JRA and uveitis and all those things, then those things tend to recur more. So that gives me a clue that the initial management in terms of cycloplegia and in terms of anti-inflammatory drops wasn't good enough to begin with for whatever reason. So that is vital. So don't depend on something like tropicamide in children. Go for homatropine drops. I even prescribe atropine ointment even with pseudophakia in children because I want complete cycloplegia in the post-operative period. And if you have a bit of doubt about the compliance, then you can maintain a more frequent follow-up. So but the initial, if you get a PCO in the first 2 months or so, I have seen you have to do vitrectomy, multiple times. That I've seen. That I basically ascribe to the lack of good post-operative management. The error could be with anyone or anybody, but go for complete cycloplegia to begin with.
Oh, these children have high inflammation also, and that.
Yes. That's the reason.
Okay. Let's go to the next speaker. We can invite Dr. Amit.
So we are coming to the end, and we have the last speaker, Dr. Amit Raj, who is the additional professor, and he's heading the Department of Ophthalmology at AIIMS Patna. His area of interest is cornea, keratoplasty, and pediatric cataract. He has published more than 25 articles in national and international journals, and he's member of various national and international ophthalmic society. And he has got the Dukaram Gold Medal by Bihar Ophthalmic Society in 2008 and the Best E-Poster Award in conference. So over to you, Dr. to present on FICO in white cataract.
Slide is visible?
Yeah, they're visible. Please carry on.
Start.
Thank you, Dr. Sucheta, for kind introduction. And at the outset, I am thankful to Pratical sir and Dr. Sucheta for making me part of this webinar. So, coming to white cataract, it is seen in mainly 3 types of conditions: traumatic cataract, maybe congenital or traumatic membranous cataract, and most common is the senile white cataract. So I will be dealing mainly with senile white cataract, and in senile white cataract, it is basically common in first in intumescent stage of cataract, in mature stage, and in hypermature stage. So, as you all know, cataract is the most common cause of blindness in India and world. So, not many studies has been done on prevalence of hypermature cataract in Indian population. But in one study, it has been found that 8.62% in rural as well as around 1% in urban population, there is prevalence of hypermature cataract. Coming to the preoperative evaluation. In addition to routine preoperative evaluation, one should go for USG scan to rule out any post-segment pathology. And another important investigation is a specular study, as there is chances of harder nature of this cataract, there is chances of greater CD, cumulative dissipative energy, and damage to the endothelium. One should go for a specular study to rule out any lesser specular count or Getty changes. Or if it is not able, even detailed slit lamp examination one should go. So, what are the different challenges in white cataract? Most important is the challenge in capsular access. So, first one is the visualization of the leading edge of axis due to absence of red flow and sometimes release of milky fluid on creating initial puncture. Another factor is the thin or fibrous entire capsule. Last one is the high intralenticular pressure that may lead to peripheral extension of the axis. These are the general recommendations that can basically increase the better the result, like dimming of operation room lights, increasing the magnification of microscope, doing surgery in oblique illumination, maybe use of capsular dye and indoor illuminator. So while performing axis, it can be done main port or side port. It depends on your comfort level. And the important thing is one should use the dye. And if possible, one should use soft shell technique because we have to save the endothelium as well as we have to counterbalance the increased intralenticular pressure. Okay. After passing the residual dye, initial punctures should be given, and one should aspirate the cortex to decrease the intralenticular pressure. And in these cases, one should use forceps for better control. Another important thing is there should be re-grasping multiple times, and there should be a refilling if you are especially you are using HPMC. So another modification of capsular axis may be two-stage capsular axis, in which mini capsular axis of 3 mm size is first created, and after aspiration of cortical fluid, one can increase the mini capsular axis to the desired size. What if there is a axis runout or peripheral extension? Most common method is to hold the torn tab as near the base as possible with capsular axis forceps and pull it toward the center. Another preferred technique is Little's rescue technique. Here, capsular axis is unfolded into its normal position and then grasped and pulled backwards circumferentially and then inward toward the center. Sometimes the axis runout is irretrievable, then one should nick the flap with vitrectomy scissor or venous scissor and continue forward with microforceps. If a stale edge is not seen, then create a nick on the opposite side and complete it backward. In cases of fibrosed and calcified intercapsule, capsular axis should be started in normal area of capsule and circumnavigated around the affected area to include it. Even if it is not possible, then use the microseizure or retractor may be used in the affected zone. There are some modality by which we can go for perfect resist. Most important one is the femtosecond laser, by which we can get uniformly circular and of precise diameter and size of axis, but there are certain limitations, especially in cases of hypermature cataract due to release of milky fluid. There can be slight change in position of enterocapsule. Another important limitation is in cases of fibrous capsule, there is higher energy required in that area. Another technique is precision pulse capsulotomy, also known as JEPTO. This device basically it can be used in cases of small pupil also, and in cases of corneal opacity. Another advantage of JEPTO is margin of anterior capsule created by PPC is much smoother and stronger compared to femtosecond laser. Another important modality is plasma blade. This uses plasma technology by which it destroys the molecular structure of capsule, causing transient formation of microscopic plasma and cavitation bubbles in the tissue. Again, it can be very well used in fibrotic capsule, but there are certain limitations. There is cost and this slight learning curve. Even the radio frequency diathermy can be used for fibrotic capsule. Most of the cases of white cataract, hydrodissection is not required, but if it is required, one should go for multi-quadrant hydrodissection with low volume fluid to prevent capsular blockage syndrome, and PCR and even nucleus drop can occur. So coming to the nucleus management, in cases of mature white cataract, entire cortex is opacified, so there is very little epinucleus. One should use vertical chop method, and vertical or horizontal chop, it depends. And generally, these cases are very easier to chop. Last fragment, one should be very cautious as there is no epinucleus, so there is chances of surge. So it should be controlled with foot pedal or by lowering the parameters. Another scenario is hypermature white Murgagnian cataract. Again, axis component is same. Most important is in these cases, posterior capsule is thin, fragile, and journals may be big. So in these cases, one can implant CTR to stabilize the journals, and it makes BC less floppy. These cases, after completing axis, nucleus should be rotated to break the corticocapsular adhesions, and after debulking the central part, while chopping, separation of posterior fibers is very important, because this fragment will not come for final emulsification. These cases, one should prefer soft cell technique to protect the corneal endothelium, And initial functions should be done with 26 gauge needle or cystosome, because there is, if you go by forceps, there is chances of peripheral extension in the initial phase itself. And advanced technological devices like plaques, Jepto, and Fogo plasma bed can give added margin of safety. Direct job technique should be Echo machine with the active fluidics, fusion fluidics give better control during nucleotomy. And in cases of irretrievable extended axis, one should never hesitate in converting in SICS or ECC. So thank you very much for listening.
Thank you, Dr. Anil, for very nicely describing the entire gamuts of wide cataract management. And I think we have already sought over the time, but still, yes, we need some time for a discussion. I don't know how many people are still there.
475 are still watching us.
No. That I know. We had a very nice,
Yeah.
despite having so many other webinars going on, we had a very nice gathering for this, because once you look into how we are making the program, it is right from the basics to advanced. That made a lot of difference. I think we had a good coverage from SICS to femtosecond laser surgeries. Any comments, Dr. Sanjeev, regarding the first talk on SICS advantages?
Yeah, I feel like SICS is the initial surgical skill every person should understand, should learn it. Because what usually we see, there has been some tendency somewhere like people prefer only phaco. But SICS is also very important part. And although we say, and another thing, although we say there is a transition from SICS to phaco emulsification, but I myself actually have an experience of that. Over the course of last 20 years, when we started phaco, we slightly converted from SICS to phaco. But later I realized after a few years that there were certain things to unlearn. So that I had to get for a training to unlearn several my bad habits to perform a good phaco. So those are very important things. So we actually, ideally, I feel we cannot say it is a transition from SICS to phaco. We should learn SICS as well and phaco, both the things.
Correctly said, Sanjeev, because as far as I am concerned, SICS was born because of phaco only, because did work on how to decrease the incision on a standard extracapsular surgery. So that could have given a birth to SICS, because we knew how to make a tunnel, other things.
Yes,
so there are various debates happening now in India. We have a largest because of society on small incision, the manual small incision cataract surgery, which is doing wonderfully well.
Wonderful, yes.
As I said, it does have its own place, and but as far as we are concerned, in our main aims, we don't give a training to residents on a SICS, because they learn first on a
gets initiated. You can have just one, the last discarded microscope, even anything. So even if they have just, even without the machine, students can start getting the feel of, the wet lab. So they know that they can learn things outside of the OT, because there is a huge difference in terms of wet lab learning and OT learning, because there is no pressure in wet lab. In OT, there are 100 other pressures on the resident, and in the wet lab, they are totally free. Their mind is free. They can and as I see, every year the innovative and the innovation level of residents is increasing. I mean, they develop things on their own. They develop techniques on their own, and they come up with new ideas on their own. So if you give them some space where they are a little free on their own, it really helps. And we are here to provide all help and assistance, share our experience. Sir, beginning of this year only, sir had suggested that we should hold some kind of a workshop in RP Center where, people who are interested in setting up wet labs in their respective areas can come. And we'll plan to hold it whenever the things improve, because that thing will have to be done in-house. I mean, it cannot be done on a virtual basis, actually, because you will have to have hands-on things, how things are running here. But you'll be happy to know that now, almost since 1 year now, wet lab training is mandatory for residents in RP Center. And they are initiated into ECC in the wet lab. Then after they learn, they take an exit exam on go ties only, and then they get certified in wet lab, and then they are allotted cases in the OT, and then immediately they are taken into FACO training. And once they go through that, they give an exit exam in the wet lab on FACO, and then they get cases. And then even after that, their teaching continues. As sir said, that we hold a video review session on every Saturday, or at least we try to do that, where the residents' videos are played and in detail, and we take them through step by step how, what went wrong, what could have been better. And so our posting is 3-month rotation posting of the JR batch. So I try to take them through each step in one class only. So I focus on one step in each class. So I will focus on Rexis for 2-3 hours. I'll focus on hydrodissection, hydrodelineation for 2-3 hours. So each step, approximately, I've broken down the surgery into 8 steps. So each step we go through almost 2 to 3 hours every Saturday. So by 3 months, they are quite well adept in basic FACO at that point. So everyone can do that. Even if you don't have wet lab, at least you can start recording. More important than the consultant cases, I think resident cases recording is more important. So even if you have a thing, you should start recording resident cases.
Okay, thank you, Tushar.
We also do recording of the residents and
steps, yes.
weeks where we discuss where they are going wrong. And what I have made them that you do each step until you are not perfect. I'll not let you do the second step. That is like
okay, that's a good one.
And you can also and instead of making them do the entire case, you can in fact, I mean, the initial steps are actually more difficult. So Rexes and incisions are actually more difficult than the later steps. So they can begin with the later steps, and then it's not mandatory to go from they can have exposure to the later steps first. And because if the Rexes get spoiled, their entire case gets spoiled. So
wet lab can be installed anywhere. You just need a small microscope, goat's eye, and then stand wherein the goat's eye can be fixed. You can go ahead with that's what we were discussing with some
there was
other
a question about the simulator, right?
Yeah, I just wanted to know, what about surgical simulators?
Yeah, we have that ISI simulator. We have an ISI simulator since many years now. And after having seen everything, it is very useful in one step, that is learning Rexis. If I have to pick up one vital step that can be almost completely learned on the simulator is Rexis, and that's a vital step. And second, coming to hand-eye coordination, again, very well in general. And there are actually 3D games in that, which the residents like. So they learn to pick up the hand-eye coordination very well on the simulator. Unfortunately, the actual FACO part, the chopping and all those things are little good or not a very good thing to learn on that. But yes, the handling of the phaco probe itself they learn, because it's quite a heavy instrument in a manner, when you first time put it in the eye, quite bulky and quite difficult to maneuver. So all those things they learn, and especially now, like for example, we have the residents number has increased so much over the last few years. They are not getting as many cases as they were getting, say, 10 years back. So the utility, and now, for example, in this COVID time, we are not getting eyes also. So the simulator again is being put to good use during this time. And people who are really utilizing it, residents, there is a complete scoring program in that. So you can actually pass through various modules and get scoring on that. So
in fact, I had a demo done by this IC Surgical only.
Yes,
See,
yes,
whatever
yes.
RP center has, I mean, my director gives permission straight away. So I got
so
the
you should,
okay
yeah, you
from
should,
director. And
it is expensive, but I think
yeah,
I think at AIMS, it is worth
Dr.
having it.
Dr. Kavita, you can go for a new buy. We are going to buy a new one just this year, which
So-
has retina attachment also.
Yeah, same, sir. I have asked
So
for
we
the
already
same with vitrectomy and this both.
we have already negotiated the price.
sir.
We'll have that, and you can we go with same.
Okay, sir. So please tell me the price negotiation also. So we will also,
Once
buy
it
it at the
comes through, you
same.
can take the purchase order or something.
Yeah.
There is a procurement, whatever done in RP center, we can basically force our administration to purchase that.
Yes.
So,
Yeah, you can. I think you
that
can
is the
use the same
benchmark.
PO.
I have
I think
procured.
you can use the same PO.
So if you give a permission next year,
No, on same
onwards,
PO they do not allow generally,
next
but at least they agree for instrument, particular instrument that you can take. Like we have procured Lumira, IL Master 700, everything on the basis of RP
next
center.
year onwards, I'll request the ministry to give the money to main aims only. We'll buy for all of you.
That will be wonderful.
That will be best, sir.
That will be.
There can be
Okay, I
central
think-
procuring agency.
Yeah, that will come up. Don't worry, it will come up.
Even our
That
negotiating
is
power
what
will go
army
up.
people do actually.
No, our
It is done
negotiating
in
power will
army.
go up if you are buying 6 simulators or 10 simulators. The price negotiation will also.
In army, it is done like that only. In R&R, they do all the negotiation.
We can have a committee comprising all people, and I think that will come up in future. Okay, I think we can summarize the meeting, and would again thank you all the head of departments from various aims joining us in Dr. Sucheta's efforts, and very happy that it worked very nicely and had a very nice discussion on every point of cataract surgery. We didn't discuss the other part, which is complication, other thing which can be in a future program for us, because complication management also has to be discussed. Professor are heading department, so I can see you have many decades to go. So you should just now think and build up a research building in main aims, your aims area, and that is required. If you don't have a research area, you will never come up. So think it over that. All these clinical things will go on, but there has to be something unique, and aims will never have a deficiency of budget for these areas. So please think on that, and we'll definitely help you if needed from our side. So I would thank all the speakers.
One small suggestion, sir, before we close.
Yeah.
I think all these 6 aims, yes, all these 6 aims, because these are new institutes, this even purchase to research to everything is different. And instead of, okay, this is fine, we have big discussion on cataract, but how these institutes to be grown, how to these residents to be groomed. And somebody like Professor TTL, we can take as a mentor, and all the aims can have similar meetings of maybe research lab, maybe
definitely.
That will be wonderful. What really Dr. Sucheta has started, I really thank her, because this sort of bringing new aims together is itself is a difficult thing. And I think we need mentoring from somebody like Professor TTL. In a group, so that we can grow in a line of participation.
we'll do that. And I'll say one more thing, you should have your own society, which can be, a research and academic society of your own. That will help you to, build up for things. Like we have, right from the inception, we have the Ophthalmic Research Association in RP Center. So that has many, many important areas. Apart from, all these meetings, you can have residents, funds there for which they can go for international travel, grants. Many things can be done through that. So work on that area also. So wish you all the best, and thank you to all the speakers.
Being all the time here and mentoring all of us and doing such a wonderful job. And special thank to Sucheta doing so, bringing everybody together. That's really great.
Thank you.
I should thank all, and especially Professor Titial for helping me in each and every step. I'm thinking I should go back to my PG, which cannot be done. I want to build at least at each step. Thank you very much, sir. And thank you, JP, for helping us out with this wonderful presentations and all coordination and all. And hope to see more of this type of interactions. And sir, please be the mentor for us so that something grows out of it. Otherwise, we just don't give for the namesake of AIMS. We don't want it to be. So that is the main thing.
Always. Not only me, the entire RPC faculty are very, very proactive. You saw there, Namrata, Rajesh, Tushar, we all are there, and it can be anywhere. Not only cataract, refractive, cornea, retina, name anything, people will be there, and that is without saying that. No, you don't have to request. If we work together, things will come up. And you rightly said, J&J people, thank you them also, especially Jaswinder did wonderful work for us. Thank you, and see you very soon.
Arvind,
Bye bye. Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Okay,
bye bye.
Thank
Bye
you,
bye.
everyone.
Bye.
Good night.
Thank you.
Thank you,
Good
madam.
night.
Good night, everyone.
Good night.
Good night.